Yes, sir.
Are you able to hear me?
Yes, sir, I am.
Yeah. Okay. We'll be starting the meeting now.
Another few minutes, sir.
Yeah. Only thing I'm not able to change that background.
Oh, is it okay?
Okay. I'm not
Okay,
able
sir.
to do it.
Okay, sir.
APA. Association of Physicians.
Arunraj sir, good evening.
Good evening. Good evening.
Subramanian sir.
How are you?
I'm very well, sir. Thank you.
Good evening, Dinakaran.
Thank
Nice
you.
to
Good
see
evening.
you after a long gap. Looking much
Yes,
younger.
yes.
Looking much younger. We are so happy to see our nephrologist. This is one advantage we have now.
Yes.
Yes, sir.
Yeah.
Ravichandran sir, good evening.
Voter.
Mohan sir.
Hello.
Mohan sir, are you here?
Sir, Dr. Ravichandran.
Welcome, sir. Dean sir, welcome.
Sir.
Good evening.
Nice. Okay.
Good evening.
Welcome. Okay, good.
Arunraj sir, good evening.
Good evening. Good evening. Yeah,
good evening, Mohan sir.
He was here since 5:30. Just some technical things, sir. So it's a 6:05.
இது வருது flickering.
So while we are waiting, I'll just say a few housekeeping things. Good evening to all. On behalf of API Tirunelveli, Indian College of Physicians and Department of Medicine, TVMCH, I warmly welcome all the speakers, delegates, and also the PGs and the stalwarts for today's evening. So it's a virtual event.
Hello.
There may be some technical issues, but kindly bear with us. And for CME credits, please type your full details in the chat box, and you are expected to attend both days to get the full credit hours. So that's important. We also have an observer from Tamil Nadu Medical Council joining us, so to oversee the proceedings also. And we have stalwarts already joined, and it's 6:05 p.m. We have 4 topics today, and I'll hand over to Dr. Mohan sir, our chairman, to conduct the proceedings, sir.
So, good evening to everybody to this online webinar. So, we'll start the meeting. So the meeting is called to order. First program is decision prayer. Dr. Meena Kumari.
Good evening, everyone. Am I audible?
Yes, very good.
Yes.
Good evening, everyone. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray that you give skill to my hand, clear vision to my mind, kindness and sympathy to my heart, and strength to my body. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the privilege that is mine. Take from me all guile and worldliness, that with the simple faith of a child, I will rely on thee. Thank you.
Now, welcome address. That is a welcome speech. So, good evening, everybody. We are conducting this CAB medicine update for the past, consequently for the past 12 years. This is a 12th year, but this year, due to this corona epidemic, pandemic, we are conducting through online. So we are missing a grand get together, but something is better than nothing. So otherwise, we'll conduct in the great manner. So today's chief guest, Dr. Arun Rai sir, is well known to everybody. He is now the national president of the APA. He is not new to our Tirunelveli APA, because he is alumnus of Tirunelveli Medical College. So when we started this APA Tirunelveli in 2003, he was the chief guest at that time also, and he has been the chief guest in 2 times for our CME. And he is not only national president of APA, previously he was national president of this IMA and Commonwealth president, Commonwealth Medical Association president. True, when I was a PG. So he is the pioneer in CME. He is the man of CME. So at that time, so previously, there were no CME in the southern part of the India. But even in the 80s and 90s, he has conducted many CMEs, so bringing stalwarts from all over India to Thoothukudi and conducted CMEs. Such a great person. So to have Dr. Arun Rai sir with us is a great privilege to Tirunelveli APA. So I welcome you, sir. Arun Rai sir.
Thank you, Mohan. Thank you.
On behalf of Tirunelveli APA and Department of Medicine, Tirunelveli Medical College, I'm very glad to welcome you, sir.
Thank you.
Then our Dean, Dr. Ravichandran, he is a very good friend of mine. So in this pandemic period, he is very busy with his COVID patients. So he is managing this more than 500 cases in the COVID wards every day. I am very
Thank you, sir. Thank
glad to
you.
welcome you, Dr. Ravichandran, and congratulate him
Thank you, sir. Thank you, sir.
for his very nice work in the COVID period. Then our HOD, Dr. Alagasan,
Thank you,
who is
sir.
also a very nice friend of mine. So he is also managing this COVID wards for the past 7 months. So we are very glad to welcome you, sir.
Thank you, sir.
Then all the speakers. So when I contacted them through phone, immediately they have accepted our request to deliver the speech in the webinar. Especially some are not new to us. Because Dr. Dhanagaran sir, Dr. Vijay Viswanath sir, and Dr. Chennappa sir, who is very busy in conducting the seminars and other meetings. And Dr. Balamurugan, Dr. Aruna Rajendran, and Dr. Dr. Mohan Prasad sir, and all the speakers. So on behalf of AP Tirunelveli and department, I welcome you, sir. Then our dynamic secretary, so Dr. Subramaniam. So for the past 17 years, I was the secretary of AP Tirunelveli. Nobody was willing to take over the job. Now I have put the burden in the shoulder of our dynamic secretary, Dr. Subramaniam. He is the present IMA secretary also. He will take the Tirunelveli AP to a higher level. So I welcome Subramaniam.
Thank you, sir.
And I welcome Dr. Managala Perumal, my close friend and my classmate, who is the treasurer for many years for this AP Tirunelveli. So I welcome Managala Perumal. And I welcome all the professors and assistant professors of the Tirunelveli Medical College who are fighting against COVID in this period. So with their support only we can conduct this. So welcome all the professors and all the assistant professors and PGs of Department of Medicine, Tirunelveli Medical College. And finally, I welcome all the delegates who have registered. So every year we are conducting the CME. So more than 300 delegates will be there in person. Now we are conducting this online. So now, I welcome all the delegates to the webinar. And finally, I want to tell one thing. So this Tapicon 2000, Coimbatore AP is conducting the first week of November, so on online. So we are going to conduct the Tapicon 2021 in Tirunelveli in July, say first or second week. I think before that this pandemic will be over. So we are ready to have a great function on the 2021 Tapicon. So once again, I welcome you all for this webinar. Thank you.
Thank you, Mohan sir. Thank you, President.
Next, Secretary's report, Dr.
Yeah. Yes, sir.
Subramaniam.
Good evening to one and all. So it's really a pleasure to be involved with the API Tirunelveli game. So I'm really glad and also humble. I have accepted the position of Secretary to API Tirunelveli. So last 1 year we have been doing, as Dr. Mohan sir was saying, so we have been doing a lot of activities every month. So since the November medicine update last year, we had a Physicians Day in December with the CME and also medal given to the students. And then January we had APICon. So we had 5 speakers from our API delivering talks. That was really a good success. So thanks to the TN APA and also National President Dr. Arulraj sir. And then from February onwards, although we had COVID in March, we continue to run monthly updates. It's there in oncology in February. Then we had a brief lull from March to May. And then June onwards, we focused on COVID-19 by Dr. Alahesan sir. And then management of ACS during this pandemic by Dr. Arunachalam. and then Dr. Toy Manuan talking about NASH in July. And also we had another meeting about approach to rheumatology during this pandemic period by myself. Dr. JB sir talking about CKD, new updates in August, and in September we had a talk by Dr. Jabbar Singh from Madurai talking about lymphoma. In addition, he also is running a weekly WhatsApp quiz program for physicians and PGs, which is quite interesting and also attended by many PGs. So that's academic side. Association side, we have conducted an election in April with online, and they also had a GB, and now we have been elected to serve for 2 years. So thank you. And then we also had a EC meeting with office bearers. These are office bearers from August onwards. So since January, we tried like membership enrollment drive. So we did in February, met quite a few associate professors and PGs, and we managed to enroll 33 new life members to National API. So I'm really glad that our numbers are increasing, reaching double figures. So so they haven't got the number yet because national EC meeting is not happened yet, but soon it will. So at the outset, I'm glad to accept and also will continue to support all API activities within Tirunelveli and also in Tamil Nadu as a EC member. And I hope this 2-day program, which is really nice, involving all specialties and the speakers from all parts of Tamil Nadu and the star speakers. So definitely there will be more interest today and tomorrow. So I request the speakers to be limiting to their time of 30 minutes talk and 10 minutes for discussion, and the chairpersons also. And you can discuss anytime also. So tomorrow there will be a PG session 2 with quiz program done by myself and also co-assistant Dr. Meena Kumari. So with that, I submit the secretary report to the August audience. Thank you.
Thank you, Subramaniam, for your report, annual report. So before Dean's address, one announcement. Again, I request everybody to enter your name, MCA registration number, an email address, and the mobile number in the chat box to get the MCA credit point. One thing I want to tell, every year we will have one theme, like knowledge. So enriching knowledge, enlightening knowledge, refreshing knowledge, spreading knowledge. So this year we have selected this, that is airing knowledge, because we are conducting so online. So airing knowledge is our theme. So for this webinar, I request our beloved Dean, Dr. Ravichandran, to address the gathering.
Good morning to all. First of all, I thank Dr. Mohan sir, my close friend, for giving me an opportunity to inaugurate and to felicitate this function. I do remember the olden days when there was a regular CME every year during the September month. It was with much fanfare, and the physicians and the general practitioners in and around down south used to admire and attend regularly this CME. We must thank Dr. Mohan sir and Dr. Subramanian sir for taking enormous effort to conduct the same CME pattern in virtual mode. So I recognize the difficulty he has taken to conduct the CME through virtual mode. And you all might be knowing that medicine is ever expanding field. Knowledge is power. So from spreading knowledge, from recognizing knowledge to realizing knowledge, likewise, this CME helps a lot in improving our knowledge. For example, last year COVID was not there, this year we are struggling with a lot of COVID patients and treating the COVID patients. And there is an explosion of knowledge about COVID nowadays. So by attending CME only, we can improve our knowledge in general medicine. So for that, the CMEs are more important, and we have to attend all CMEs which are available virtual or by direct mode. As Dr. Mohan sir said, he may be able to conduct the Tapicon in Tirunelveli, not in virtual mode, in a real mode in July 2021. So I wish the function a great success, and I wish his effort to continue still further. Thank you, sir.
Thank you.
Thank you, Dr. Ravichandran. Now I request our professor and head of the Department of Medicine, Dr. Dr. Alagesan sir, to address this gathering.
Good afternoon to all. Respected Chief Guest, Dr. Arulraj sir, and respected APA Chairman, Tamil Nadu APA Chairman Dr. Mohan, Subramanian, APA Secretary Tirunelveli, our beloved Dean, Professor Ravichandran sir, our Treasurer Monakavalam Perumal sir, and all other distinguished speakers today. I extend my warm welcome all of us. And time flies, and we have crossed almost 8 months in this pandemic. So let me thank and congratulate all the frontline warriors in this pandemic, not only in our government side, department side, and also a lot of the private practitioners for their wonderful humanity service. So I am honored with an opportunity given to me to share a few words regarding the CME and the medal function. So our profession needs a continuous update of skills and theories of evolving in the branch of medicine. So we need to constantly update our knowledge. And I congratulate and thank our Professor Mohan sir for his outstanding performance in conducting this type of CMEs. And all our students have done well, hard worked, and have done everything possible to achieve the results and show what they are capable. So I congratulate all the medal winners, UG medal winners, Alvin, Abhisha Grace, and our PG winner, Dr. Soumya, for their excellent achievement. Thank you.
So thank you, sir, for your nice words. Now API award presentation. Every year we will give a shield and a certificate to the top scorer in the university examination for both the PGs and UGs and the medal exam winners. So this year also we have medal winners and the final year toppers. So I request Dr. Subramaniam to read their names. I request the awardees to unmute your video and show your face. Awardees, please, when your name is read, please show your video. Right, Subramaniam, proceed.
Yes, sir. So can you see my slide?
Yes, yes.
Okay, thank you. Congratulations to all the award winners. So on behalf of APA and also Department of Medicine, we congratulate the UG winner. So 2 awards to Dr. Alvin Kurian Raju and Dr. Abhisha Grace. So both are MBBS UG Medicine Medal winners for 2020. Great congratulations. So we can see Abhisha in the photo here, and also
Yes.
Alvin is here. Okay. So all the best for future success too. Yes.
Abhisha,
Yes. Great.
unmute.
Yes, sir. It is unmuted only.
Okay.
Okay. Audible.
Yes, sir. Is it audible, sir?
Yes.
Yes, audible.
Okay, so should I speak now?
Only a few words.
Good evening to everyone present here. I'm so grateful for this evening. I'm thankful to God that He gave me this opportunity to speak in all the great persons sitting in front of me. And this evening, I'm really feeling nervous. I don't know what to speak. I would like to thank all the chiefs who have and assistant professors who have helped me to achieve this position. I would like to thank Dr. Allegation sir, who was my chief for the last 2 years. He has not spoken much to me, but every time I see him, I take a lot of inspiration from him. He's so calm, he's so composed, and every single personality of him has inspired me. And I would also like to thank Dr. Mohan sir. I don't know whether sir knows me, but from my third semester, my first clinical year was with Dr. Mohan sir. He was my chief by then. And the first day he asked us to bring all the instruments. We didn't even know what was the CNS kit, but he forced us. He created so much interest in medicine, and a special mention about Srinath sir, PG, who was present final year PG when I was in third semester. The interest towards medicine was mainly created in me by him. He was so, like, what to say, he taught every single meaningfully, and I fell in love with medicine at that. By the years to go, every single posting in third semester, fifth semester, seventh and ninth semester, every semester, I used to enjoy going to medicine postings. I didn't even take a single leave for medicine postings. And every chief's class, Martandam sir, Rafi sir, every class was so useful to us. I would like to thank all the chiefs and my assistant professors, Gracia ma'am, Ahmed sir, Meena Kumari ma'am, Vinoda ma'am. Every assistant professor used to help me a lot. I would like to thank every one of them, and a special thanks to Martandam sir. He was chief when I was doing house surgeonship. I have completed my medicine posting. He used to come to rounds regularly and teach a lot. Even in this pandemic situation, he used to come and tell something to us. I really like to thank every one of you. And finally, I would like to thank my parents who have helped me a lot during my final year. And thank you, everyone. Thank you, API, for this recognition. Thank you, sir.
Thank you. That's good. So, is okay. Be short, Alvin.
Good evening, everyone.
Time is very short.
Okay, sir. I would like to thank everyone for giving me the recognition. I would like to thank all the unit chiefs, especially my chief during my final year and third year, Dr. Allegation sir, and our assistant professors, Dr. Gracia ma'am, Ahmed sir, Vinoda ma'am, and all our postgraduates, especially Harsubhashini ma'am, who used to give me notes, and she used to help me a lot during the examinations. And I thank every unit chief, especially Ratna Kumar sir, Martana sir, Rafiq sir, for giving me the for giving me such a inspiration and making us learn medicine.
Okay.
Thank you.
Congratulations. Thank you.
Next.
So,
Next.
yes, I think he has taken to another slide. Yeah. Okay. So next is medicine college first rank appreciation award to Dr. Bharani Gomati. Congratulations.
Thank
Are
you,
you
sir.
here? Okay.
Is it audible?
Yes, please go
Yes,
ahead.
audible. Be
Good
brief.
evening, respected sirs. I first thank APA Tirunelveli, Dr. Professor Mohan sir, Professor and Head of the Department, Dr. Alagesh sir, Dean of our college, and everyone for arranging this function. I feel very honored to be a part of this meeting. I take immense pleasure to thank Dr. Professor Ratnakumar sir, my unit chief. This day would be impossible without him. The first thing we admire about him is sincerity and dedication. All the OP classes, board classes will be very interesting. I thank all the chief sirs, and I also thank my parents for their unconditional support and love. And I thank my unit professors, Dr. Govindaraj sir, Rajkumar sir, and Javakar sir for their constant guidance and support. I also thank my PGs for their extra care. And I thank my twin sister for being a best companion and competition. Thank you, everyone.
That's good. So that's really appreciable. Next will be the PG Abandon. So
Yes.
Next.
okay, so that's Dr. Soumya. So she is first in MD Medicine in our college, and also the gold medal winner for the medal exam. So she has done very well. So congratulations to Dr. Soumya joining as a physician again. So Soumya here, yes, welcome.
Only few words.
Thank you, sir. Thank you so much for the appreciation. I want to thank our unit chief and the HOD of medicine, Dr. Alagesh sir. He guided me right from the first day. He gave me so much confidence in how to approach a case clinically, and I will carry that confidence throughout my career in my life. I also thank my tutors guiding me through that.
So really inspirational faculty. So I'm really thankful to all the faculties from medicine in TVMEC. Thank you. Over to Mohan sir.
Thank you, Dr. Subramaniam. So we should thank the unit chiefs, Dr. Alagesh sir and Dr. Ratnakumar, and other all the assistants who made them to achieve these achievements.
10 minutes, I'll come.
Thank everybody.
I'm in a webinar, கொஞ்சம் delay ஆயிடுச்சு.
Next, our chief guest address, so Dr. Arun Rai sir.
Good evening to you all.
Good evening, sir.
Thank you, Dr. Mohan. I mean, a very veteran, physician, committed physician. Right from his postgraduate days, he is with me. I am seeing him growing as a professor of medicine, as a chair of Tirunelveli, branch of API and Tamil Nadu chapter of API. I wish he should occupy this chair which I am occupying today in his, lifetime. Sure, with his continued effort. We used to call it as a perseverance. And you want something, you will have to persevere. See that you keep on chasing it. He is a good chaser. I am sure he will be able to get it. And I am here on three, pedestals. One as a physician practicing with you all in a nearby city. And first of all, I will put it as an alumni of Tirunelveli Medical College. I am a product of Tirunelveli Medical College, which I proudly say globally. Globally, everybody used to ask, where is Tirunelveli? Those days when we were undergraduate, Tirunelveli was such. But today, Tirunelveli is a monument. It is a medical monument. And I could see the developments in the, hospital sector, healthcare sector, and great appreciations to the corona support that they have given. Though there may be many, private sectors, who are supporting, nothing can beat a public sector care in the corona, which I have very boldly said to our Honorable Health Minister, both Union and the Chief Minister of Tamil Nadu State, especially the three down south medical colleges, Tirunelveli, Thoothukudi, and Kanyakumari, have done an excellent job to save the lives of the suffering. People below the PPL. I should really appreciate and congratulate. And Tirunelveli API, as Mohan said, I mean, we have been doing a monthly, CME. And CME is the live wire. As our dean said, CME is the live wire. And we call it, internationally, we call it as a CPD, continuing professional development. From CME now, it's only same, only a word is, different. Unless you keep on updating your knowledge and skill, you will get lost. See, for example, COVID, none of us know. Either as a senior person, me or Mohan, nobody knows. We are not taught about COVID. Today, COVID has grown to such an extent that we have given the title of a COVIDology. Something like cardiology, nephrology, neurology. COVID science has become a COVIDology. To that extent, it is a multi-system thromboinflammatory, vasculitis. That is how it goes. All these things we will not know unless we attend these CPD programs. Going through these CPD programs, I found it to be extremely well structured, academically well structured. I am sure all the delegates, both the young physicians, postgraduates, and upcoming physicians will definitely be benefited with the scientific sharing by the learned faculties like Chenniyappan, Dr. Dinakaran, Dr. Vijay, and all the faculties are, they are well known not only in India, beyond India. When they have all agreed to come on this platform means I am sure all the participants will be benefited. Lastly, before I close up, I have an appreciation for digital meetings. Today, we are not only having a digital learning, we have a digital education, we have a digital healthcare. I am passionate about digital healthcare. When I was in the chair of Commonwealth President in 2007, we initiated e-health, electronic health. It used to go only through a desktop. Then it came to m-health, it is mobile health. Then it came to i-health. When artificial intelligence was combined, intelligent health was there. Now global terminology is digital health. Now today, APA, we are all locked. We are not able to even have any meeting, either official meetings or academic meetings. But APA is highly vibrant today, highly vibrant. Every day, even now I'm rushing for a webinar. Mohan knows it. From 7 o'clock onwards, he always wants it to be trouble-free. But digitally, there is always some interferences there. Continuously, we have, every day 2-3, digital meetings, either meetings or conferences. Now our cardio diabetes conclave, which used to have it every year, is going digitally. And APA is also going digitally. This 2021 will not happen. We are planning how we can do a digital conference and try to complete the elections and change the president. Therefore, digitalization has become part of our life. Thanks to our Honorable Prime Minister of our great nation, who is envisioning a digital India. We as healthcare professionals, we are passionate about digital healthcare. And I was appreciating the young doctors who have been awarded for their performance. It's a great encouragement. If you go to APA website, for the postgraduate, excellent programs are available. From Fluxus, we are tied up for digital medical education programs. You can go into that website and try to register. You will be able to upscale your knowledge and skill. That is an APA supported. And there is a hot valve program which APA support. I think I have shared the details with Mohan and our APA people. If anybody wants it, they can text me. I'll do that. It's going to start on 18th. It's a free course for physicians to empower them to make a clinical diagnosis. When you go for an examination, you will be able to say how to say that this is a valvular heart disease, congenital or acquired, and a left-sided, right-sided with pulmonary hypertension. Without pulmonary hypertension, there is a rhythm disturbance. All you will be able to do. It's an initiative of APA, but it is being offered by one of our Tamil Nadu premier institution. It is a credible venture by Tamil Nadu physicians and cardiologists. You can, all the youth can definitely enroll. It is complimentary, can definitely learn. And there is a COVID course also available in API website. That is also free. There are a lot of CPD programs are available. API is science, API grows science, API support science, evidence-based science. And I wish this 2-day seminar a grand success. And with great thanks to you all, I take leave from you all. Thank you. Thank you.
So thank you, Arul Rai sir, for your nice words and nice advice for the young doctors and PGs. So we are begin the schedule. 10 minutes begin the schedule. And then a vote of thanks by our Thiruvananthapuram Medical College Medicine Department Registrar, Dr. Thomas Kingsley.
So good afternoon, sir. It's a privilege to offer the vote of thanks for the virtual annual CME Medicine Update 2020, organized jointly with the API and the Department of Medicine. Today, I'd like to thank Professor Dr. Arul Raj, the president of the National API, perhaps the first one from down south to Tuticorin. Thank you so much, sir, for always your encouraging and supportive words and for your gracious presence here. I'd also like to thank our Dean, Professor Dr. Ravichandran, sir, is always supportive of any academic meet at any point of time. He keeps on telling this. I've been a long assistant to him. Thank you, Ravichandran, sir, for your presence. And I thank Professor A.S. Mohan, the former HOD of Department of Medicine, present chairman of the APA, both Tirunelveli and Tamil Nadu, who is ever energetic in organizing this kind of academic meet. Thank you, sir. And I thank Professor Alagasan, HOD of Department of Medicine, is also the nodal officer of the COVID in TVMCH in spite of his busy schedule, we all know. But his always prerogative is the academic sessions for the postgraduates all the time. Thank you so much, sir. And Dr. Subramanian, Secretary API, who is organizing the whole thing. Thank you, Dr. Subramanian. And Dr. Meena Kumari, who along with Dr. Subramanian will be conducting the quiz program at the fag end of the day, day 2 session. I thank both of them. And Dr. Managava Perumal, Treasurer of the APA, thank you, sir. And I thank all the speakers for today's and tomorrow's session. Dr. Mohan Prasad, Dr. Vishwanathan, Dr. Chennappan, a darling of the cardiology, and Dr. Dinagaran, the darling of the nephrology from the Madurai Kidney Center. And the chairpersons, Dr. Kandasamy, sir, HOD of Department of Medical Gastroenterology, Dr. Ravi Edwin, sir, HOD of Cardiology, Dr. Ramana Subramanian, sir, HOD of Nephrology, and Dr. Syed Sulaiman, consultant physician from Tengasi, and also the speakers for tomorrow, Dr. Bala Murugan, Dr. Parandaman, and Dr. Aruna Rajendran, and Dr. Nirmal, along with the chairpersons for tomorrow, Dr. Alagasan, sir, Dr. Madhav Rafi, sir, Dr. Ratna Kumar, sir, and Dr. Nalla Muthuswamy, sir, the consultant physician from Sangaran Goyal. Also take this moment to thank Dr. Rajagopalan Marthandam, sir, Dr. Sindamarai, sir, and Dr. Perisamy, sir, professors of Department of Medicine. And I take this opportunity to thank and wish all the medal winners, Dr. Bharani Gomadi, Dr. Alvin Kurian Raju, Dr. Abhisha Grace, and Dr. Soumya, the PG medal winner, and their proud parents also. And I take this opportunity to thank all the delegates, the physicians, the faculties, the general practitioners, the postgraduates, everyone online, eager to have the feast of the Medicine Update 2020, and all the technical people involved and the sponsors, if any, involved in this. I'd like to thank my warm and sincere thanks to all of them. So again, thank you all once again. Let me hand over the mic to Dr. Subramanian to hand over the presentation. Thank you.
Thank you, Thomas. Thomas.
Thank you.
So we'll start the CME. So before that, I request all the participants to enroll their presence by entering your name, MC number in the chat box, and any question you can enter in the chat box. So I hand over the mic to Dr. Subramaniam to start the CME. So because we are 50 minutes short, that is begin the schedule. So I request all the chairpersons to conduct this CME in the scheduled time limits. Thank you. Over to Dr. Subramaniam. start. You can start.
Thank you, sir. Thank you. So that's the end of inauguration. We'll go on to the academic session. So first will be the chairperson is Dr. Kandasamy, HOD Gastroenterology from TVMCH. So welcome to Dr. Kandasamy. The speaker, yes, sir. I'm just going to share the slide of the speaker, and then Dr. Mohan Prasad, MDDM, FRCP Chairman, VGM Hospital, Coimbatore, is here to talk about malabsorption, evaluation, and current approach. So just give me a minute, I'll share the.
Thank you, Subramanian.
Yes, sir.
I have a privilege to introduce our beloved Dr. V.G. Mohan Prasad. He's a very dynamic personality, and he has touched almost all the areas of gastroenterology, and he's excelled in such excellent interventional procedures. He's having 33 years of excellence in the field of gastroenterology, and he's a past National President of Indian Society of Gastroenterology and Society of Gastrointestinal Endoscopists of India. He's adjunct professor of Tamil Nadu Dr. MGR Medical University and advisory member of National Board of Examination. He has many credentials to him, and the inventor of HemoSeal spray as an invention. It's an endoscopic device to control bleeding from the gut, and he is a two-time winner of the Guinness World Record of Hepatitis Awareness Program, and a Best Doctor Award by the MGR Medical University, and the Best Performing Doctor Award from Ministry of Health and Family Welfare, Tamil Nadu, and Best Entrepreneur Award from Times of India, and Star of India Award, and past Deputy Governor, and there's many other credentials. Welcome, you, sir.
Welcome, sir.
My gratitude to the chairperson, beloved Professor Dr. Kandasamy Alois Kumar, and my salutations to the API Tirunelveli chapter for inviting me to be a part of this prestigious CME program. So I'm a little nervous because I'm going to be the opening batsman, because in any cricket match, it's the opening batsman who sets the pitch and the trend. I hope I am able to deliver a proper job. Now, can I move on to my slides?
Yes.
My salutations to Professor Arul Raj, who's a national president of API, who's world-renowned in the field, making India proud. Professor Mohan, who's the present president of Tamil Nadu chapter of Association of Physicians of India. Professor Subramanian, who's the secretary of API Tirunelveli. So with these few words of my gratitude to the team, I'm just going to share my slides.
It's a 2020 match, so you can fire away.
Wow, I'm grateful.
Thank you. Yes, sir, nice.
Yeah, I put up your Nellaiyappar temple and one of those dams, which is so beautiful. So I thought I should just, I would love to come to Tirunelveli, because never been to Kutralam. At least I hope Kandasamy would take me next time. I hope the corona, eases out so that we can move. We are all now prisoners of war. I think now that corona is really on the rise, we are really worried. So my prayers to all of you to stay safe and be as careful as possible while examining patients, because we don't know where we are getting corona from, how corona would affect us. We have crossed 6 months, maybe another 3 months. With the vaccine coming in, we should be able to conquer the disease. And coronology, whatever, or COVIDology, is a big science in itself, as Professor Arul said. I'm going to talk to you today about malabsorption syndrome. What is the definition? What is the physiology of digestion and absorption? And then I'm going to speak to you about the pathophysiology, etiology, what is the changing epidemiology, what are the clinical features and investigations, how to diagnose malabsorption syndrome, specific diseases and their management, and an approach to a case of malabsorption syndrome. It's such a huge topic, but let me try and go through very fast so that I finish before 30 minutes. Then we have a 10-minute question answer time. I don't know whether we'll have time because already we are running short of the whole time. We have started at 7 o'clock almost. So we are half an hour behind now. So I'm going to focus on how to evaluate what is a case of malabsorption syndrome. If somebody comes to you in your clinic or your hospital with a malabsorption features, how to arrive at the diagnosis and what are the common diseases causing malabsorption in India. So what is malabsorption? Malabsorption is defined as a pathologic interference in the normal process of mucosal absorption and transport, leading to defective absorption of nutrients. So nutrients are either not absorbed from the mucosal surface or they are not transported. Maldigestion is a defective hydrolysis of nutrients, but we are now talking about malabsorption. Okay, so if you look at the carbohydrate digestion, the digestion starts in the mouth to the postgraduates because it's the carbohydrates of complex polysaccharides like starch and glycogen are treated by the salivary amylase here in the oral cavity itself. So the digestion starts in the oral cavity. My own teacher, Professor Madana Gopalan, used to ask us as postgraduates, where does digestion start in South India? If you say the mouth, he'll say no. It starts in the hand. Says nalla passage. So the digestion starts in the hand, he used to say. Whereas the North Indians, eat the chapati, roti and all that, the digestion starts in the mouth. So the amylase, salivary amylase degrades the polysaccharides, complex polysaccharides into smaller polysaccharides and maltose. And then these polysaccharides are in the lumen there and they are getting broken down to maltose and other disaccharides. And then they are converted into the monosaccharides by the brush border. So here the polysaccharides are broken in the lumen because of the amylase that comes from the pancreas. So initial salivary amylase, pancreatic amylase, and then the action by the small intestinal epithelial border, the brush border of the epithelial barrier. So finally it becomes monosaccharides like glucose, galactose, and all that. Then that gets absorbed without any difficulty. You have proteins, they're broken into small polypeptides in the stomach because of pepsin. And after that, these polypeptides are acted upon and again broken down by the pancreatic enzymes like trypsin, chymotrypsin, and all that. Then they are converted into amino acids in the lumen itself. And then, even smaller peptides can be broken by the intestinal epithelial barrier. That's a brush border. And then ultimately the amino acids are absorbed. The nucleic acids are also digested the same way. And the fat is also digested the same way. But fat digestion happens in the second part of duodenum, where the bile flows and it converts because the fat is not water soluble. So it's just insoluble fat globules are surrounded by the bile salts. So finally, these fat droplets are surrounded by bile salts, which not only help in the absorption later on in the intestinal border, also preventing smaller fat globules from joining together to form bigger droplets. So ultimately, it is glycerol, fatty acids, and glycerides all done in the lumen and then absorbed by the gut. This is the physiology. Okay. Now, there is a sodium co-transporter pump, which just transports the sodium and the monosaccharide like glucose and galactose and all that into the cell. From the cell, there is a facilitated diffusion into the bloodstream, capillary, and the glucose and all that goes through that way, the monosaccharides. Of course, I told you the bile salt forms a layer around the fatty acids. The fatty acids are converted into triglycerides, coated with protein, and they diffuse, they are exocytosed, and then they get into the lacteals and go to the liver. And also to the other, system through the lacteals, going through the, the chylomicron pathway. Right. The pathophysiology of malabsorption so involves three things. 1, luminal factors. 2, mucosal factors. 3 is a post-mucosal factors. So, and rightly, Hippocrates told in 400 BC, the death sits in the bowels. The bad digestion is the root of all evil. And today we all accept it. Okay. So, pathophysiologic mechanisms, first is luminal. So, in the lumen, the absorption is enhanced or helped by the bile and the pancreatic enzymes we saw. So any reduction in the bile or pancreatic enzymes, like could be liver diseases, biliary obstruction, bacterial overgrowth, chronic pancreatitis, pancreatic resection, all this can interfere with the absorption of carbohydrates, proteins, and fats. Again, consumption by bacteria, bacterial overgrowth. I'm going to talk to you about SIBO, small intestinal bacterial overgrowth syndrome. So this is all luminal, either because of all these deficiencies or because of bacterial overgrowth, bacteria consuming the nutrients. Then pathophysiologic mechanisms in the mucosal level could be reduced mucosal digestion. Like for example, one of the commonest that we see in the Asiatic race is a lactase deficiency. So lactose is not broken down into glucose and galactose, so absorption cannot happen. So this is one of the examples. So mucosal digestion. And then mucosal absorption. It could be diseases of the small bowel. The mucosa itself is, disease, like in Crohn's disease with ulcers or celiac disease and things like that. So absorption goes down. So it could all be because of tropical sprue, celiac sprue, and then disaccharidase deficiency like lactase deficiency, Crohn's, lymphoma, IPSIP, short bowel. Just touching upon a few points of these. And the third is a post-mucosal. So luminal, mucosal, post-mucosal diseases. So reduced transport from the intestine could be because of congenital problems, intestinal lymphangiectasia or A-beta lipoproteinemia. And one of the important things for physicians is congestive cardiac failure. Many patients of congestive cardiac failure come to us with, lack of appetite, anorexia. And you can't just go ahead and straight do an endoscopy on them because you can probably trigger arrhythmias there. Or can produce more precipitate cardiac complications. So you have to clinically look at the patient, ask a history, examine the patient, and patient, JVP will be elevated, there may be fetal edema, he may be anemic, he may be dyspneic at the room temperature, he may be tachycardic, and all that should prompt you towards CCF diagnosis. So CCF is like the patient asks, why is this? I don't have an appetite, I'm not able to digest. I tell them it is very simple. Like you have say for example, you have a water pump set, you have a sump down. The pump has to pump it up and send it to the overhead tank. If the pump is defective and the water keeps on flowing, how would the tank, take it? So a tank overflows. That's exactly what happens. All the absorbed nutrients go through the portal vein into the liver for further metabolism. So if there is a stasis because of poor cardiac pump, the right side and heart failure stasis, there is a swelling, hepatomegaly, and there is congestion. So the nutrients cannot be taken up. So this is very simple. So you have to address the heart. So you understand so many things can cause malabsorption. So in a given patient, you have to be very alert. I'm sure most physicians are very, very shrewd and alert when compared to we endoscopists like Kandasamy and myself, we look at the patient through the whole and not as a whole. Because we are gastroenterologists, my chief used to say, don't look at the patient through the whole, look at him as a whole, WHO. So you have to look at him as a whole to diagnose malabsorption. And in the epidemiology, the tropical sprue and infections were the most common causes in the tropics, and celiac disease in North India. We don't see much because we don't consume much of gluten in the diet. And other causes are less likely and not very sought after, but we have to probably work up more if the patients do not fall into these categories. Okay, so this is what is the spectrum. This is an SGPGI in Lucknow from Uday Ghoshaal's group. And if you see, they took these 99 consecutive patients 2 decades back, and they found tropical sprue by far was the commonest. Then comes celiac disease, only 9%. Then Crohn's, SIBO, giardiasis, and intestinal tuberculosis. All this is much less. Okay, so this is the common things are tropical sprue, celiac, Crohn's, SIBO, giardiasis. This is in digestive diseases sciences. This is from All India Institute study, which shows celiac is 44%. This is not in agreement with our South India because we don't see much of celiac disease. I'll show you the example. This is a study with 50 adults, 50 children with malabsorption, again showing celiac as a prominent thing in All India Institute of Medical Sciences. They show that even PG, All India Institute of Medical Sciences has steadily recorded an increasing number of celiac disease, whereas we don't see much of celiac. So population-based studies also they did in Chandigarh, they found 1:120, and in school children 1:310. So they concluded celiac is the most common cause in our country, and tropical sprue and intestinal parasites are common causes, but this is not true in South India. Celiac is extremely uncommon. Look at this study by Malathi Satyasegaran et al. From Chennai. So who just took 98 children and published, with chronic diarrhea. They found that 15.3% of children were positive for celiac disease. And out of these, only 2% were from Tamil Nadu. So please remember, if you see 100 children with malabsorption, that is, diagnosis of celiac disease will be about 15%, and in Tamil Nadu only 2%. Right. So what are the other causes of chronic diarrhea in Tamil Nadu among children? Lactose intolerance, cow's milk protein allergy, and HIV, tuberculosis, cryptosporidiosis, cystic fibrosis, factitious diarrhea, acrodermatitis enteropathica, chronic pancreatitis, lymphangiectasia, Crohn's, and then others. Right. So what are the clinical features of malabsorption? Now we looked at the causes of malabsorption. Commonest causes still are tropical sprue and giardiasis and lactose intolerance and things like that, and then parasites, Giardia lamblia infection. So the patients of malabsorption present with chronic diarrhea, that is the most common symptom. So it's defined, any diarrhea that goes beyond 4 weeks is called chronic diarrhea. Any diarrhea that is less than 1 week is called acute diarrhea. In between, they call it subacute, but not a very defined terminology. So there is an abnormal passage of loose or liquid stools more than 3 times a day, and a volume of greater than stool volume of greater than 200 grams a day. So can you please unmute your, mute your mics. Those who are not speaking, please mute your mics so that there's no disturbance. Okay. So following questions are to be answered. When you see a patient with chronic diarrhea, it could be malabsorption or it could be something else. But we have to ask these questions. Is it organic or functional? Is it small bowel or large bowel? Is it with malabsorption or without malabsorption? I'll show you some examples. So you have to take sufficient time to elicit proper history. Organic from functional, small bowel from large bowel, with or without malabsorption. Okay. So how do you differentiate an organic from a functional diarrhea, chronic diarrhea? Duration of diarrhea here is shorter in organic, longer in functional. Say 10 years I've been having this diarrhea. This is not organic diarrhea, unlikely. Nocturnal diarrhea is something abnormal. So if somebody says, I wake up in the night to pass motion, loose motion, so that is not IBS. You have to work up more. There's something pathologic going on in them, or could be some infections. Significant weight loss, features of nutrient deficiency, and multiple somatic symptoms are not there. So usually these are sympathy seekers, the functional guys with a lot of other symptoms. Small bowel, frequency usually is more. Volume is a large volume diarrhea because water is, large amount of water passes. So there's a large volume. So and then blood and stool is unlikely, and steatorrhea can happen here, but not in the large bowel diarrhea. Large bowel diarrhea is volume is small, and sometimes blood and mucus could be there, which could tell us it could be IBD, ulcerative colitis. Nutrient deficiency also could be in the small bowel diarrhea. Okay, somebody presents with abdominal pain and diarrhea, you should think of pancreatitis, Crohn's, tuberculosis, abdominal distension and flatulence, and the steatorrhea. So is it malodorous, bulky, foul-smelling, light, floating, greasy, sticky motion? That is steatorrhea. So if somebody has this sort of a bulky steatorrhea, then that means there is a fat malabsorption. So ascites can prompt you to some other diseases, or because of protein loss. So extraintestinal features could happen because of nutrient deficiency or because of underlying multisystem disease. And they give a valuable clue to the underlying, etiology. So it examine head to foot. So first, if you see the clues to the etiology and clues to the nutrient deficiency, or ocular. So start with Bitot spots, and then comes the anemia. Then comes uveitis, which could tell you that it could be IBD, could be Crohn's disease. And oral cavity, the magenta red tongue could mean it's B12 deficiency. Ankylostomatitis could tell you it could be multiple vitamin and even selenium and other mineral deficiency state. This is an oral aphthoid ulcer. which could give you a pointer that could be Crohn's disease. So these are the clues, like cutaneous. This is follicular hyperkeratosis, which happens in vitamin A deficiency. These could be bruises, which could be vitamin K deficiency. And this, of course, I'm going to show you more on this, on celiac disease, as a part of celiac disease. This could be, erythema nodosum, which could tell you it could be IBD associated. Nails can have, pitted nails, and koilonychia you see here, which could all point out towards different, problems of nutrition deficiency states. The musculoskeletal osteoporosis, osteopenia, elevated JVP, I told you, could mean take you to the dilated cardiomyopathy, which could also cause malabsorption, growth retardation in children, infertility in adults, and then diabetes mellitus, nervous system, ataxia, could be a peripheral neuropathy, or it could be even cerebellum. So you have to look at all that. So a frank nutrient deficiency rarely is encountered, but subtle signs should not be missed in a malabsorption syndrome, right? The local epidemiology and patient symptoms and signs will direct the doctor to choose the right test. There is no single gold standard test here. How do you investigate a case of malabsorption? To confirm this or suggest a malabsorption, screening tests are chemogram, CBC, ESR, LFT, stool, and then D-xylose test, and then the hydrogen breath test, which are lactose, glucose, lactulose. And then to confirm the etiology, you have to do the celiac serology, stool examination with special stains. So HIV serology, endoscopy and mucosal biopsies, and radiology, of course. The screening test, of course, so you can diagnose anemia, all of your physicians. So different types of anemias like the iron deficiency and the macrocytic megaloblastic anemia or Burr cells, and all this you can find out from just a peripheral smear. A peripheral smear will help you. And then, of course, a liver function test is that cholestasis, bilirubin will be up, gamma glutamine will be up, alkaline phosphatase will be up. So it could be associated with celiac disease, could have hepatologic problems, transaminitis. And then alkaline phosphatase, high alkaline phosphatase, normal gamma glutamine will indicate that it could be osteopenia, osteoporosis, something happening in the bone. And then the globulins are increased in different disorders. You can just look at all this and have a proper stool inspection. I used to sit and see the stool of patients under microscopy. So I used to pick up Giardia trophozoites, like I've seen the amoeboid movement of the Giardia trophozoites under microscope. It's really fascinating to see that. So you'll have to take a fresh sample and keep it on a slide and look at it. 35 years back, my teacher, Dr. Madana Gopalan, taught me at the Madras Medical College how to diagnose Giardia trophozoite under microscopy. So even today I can do that. So have a proper stool examination, do a fecal fat analysis, special staining for parasites, I'll just show you. So fecal fat analysis, like CNC Vellore used to collect the, 6 days, 5 days, they'll collect the complete motion in a bucket and then churn it and weigh it and then take a sample. Today, nobody does it. It's so difficult. So you just do a qualitative analysis, just take a fecal droplet and then stain it with Sudan 3 stain and then up to 100 fat globules of less than 4 millimeter diameter. Under HPF is normal, but anything above that could be fat malabsorption, sensitivity of 78%, specificity of 70%. So parasites, at least 3 examinations. The common organisms that we see is Giardia lamblia in our place, iodine staining or modified trichrome can help. And then Cryptosporidium, Cyclospora, Isospora belli can be seen on modified acid fast, AFP, modified acid fast. Microsporidia can be picked up again on modified trichrome. So if you can do an iodine staining, you can do a modified trichrome, modified acid fast, you can diagnose all these parasites. So the commonest is lamblia, but we have seen Isospora in Coimbatore, Cryptosporidium also we have seen occasionally. When Microsporidia in one patient who went to Africa on safari. So, right. So this is the Giardia trophozoite. My pathologist gives a beautiful picture of Giardia in the small bowel. So one of the commonest organisms in my place, at least in Coimbatore and Urmalpet and other places, I'm sure in Tirunelveli also, Giardia can live in the free water. It can live, and it is available in the well water. It's available in the borewell water also. So you have to be not only the corporation water, even the well water can supply fresh Giardia. So you have to be very careful. So ask them to boil the water and drink that. The first thing that I teach them, Isospora oocyst on modified acid pastane. This is Cryptosporidium. This is Cyclospora. D-xylose test, not readily, routinely being done, but it's very simple. So D-xylose is a simple sugar that gets absorbed in the proximal small bowel and then gets excreted in the urine. So if your proximal small bowel, the jejunum and the proximal ileum are normal, then that means the D-xylose will be absorbed and then excreted in the urine. So you give a 25 grams of D-xylose orally and then draw a blood sample after 1 hour, collect the urine for 5 hours and then measure D-xylose levels. Then that can tell you whether D-xylose is malabsorbed or normal. So this is a very good test. So anything about below 20 milligram per deciliter is abnormal. That means the absorption is defective, the small bowel absorption. There can be some false positives, false negatives. I'm not going through all that. So this is very good test which can be used. Breath test I've been using since 1994. I was the first one to get this equipment from United States and start the lactose and the glucose and the lactulose hydrogen breath test. See here, this is a simple machine. The big machine, the Quintron, need not be used now unless we want to measure methane and hydrogen. If you're measuring only hydrogen, this is enough, the tabletop model, simple. So what you do is a test sugar is swallowed. And if there is a small bowel bacterial overgrowth in the proximal small bowel, then immediately the bacteria start fermenting, so the hydrogen starts coming in. On the other hand, if there are no small intestinal bacterial, pathogenic bacteria not there, and the sugar is not malabsorbed immediately, so sugar gets down to the large intestine where they are fermented. So after 2.5 hours, the peak will happen. So from the peaking, you can understand easily. So we don't give now 50 grams, we give 25 grams. So that itself is enough, as shown by Uday Ghoshal study. So we do 30, 60, 90. So we give a drink of the sugar and then ask the patient to breathe into the machine at 30 minutes, 60 minutes, 90 minutes, 120, 180, 240 like that. We don't do 240, 180 and all that. It's enough if you do 30, 60, 90, 120. Any hydrogen rise above 20 parts per million from the baseline is abnormal. So that is a utility of this test. Is very good. It's simple, but there could be false positives, false negatives. These are some examples of mine. This is a normal breath test. This is a lactose hydrogen breath test. So anything below 20 parts per million, the red dotted line is normal. In this case, this gentleman had a gas bloat of 4 months and diarrhea on and off. Had a by 45 minutes, by 1 hour, it just went up. See, that means there is a small intestinal bacterial overgrowth in this gentleman. By 16 minutes, by 45 to 16 minutes, it's going up. That means there is a SIBO, which is producing this lactose, or there is a lactase deficiency or disaccharidase deficiency in the intestine. So we have to do an endoscopy, do a culture and biopsy. So the glucose or the lactulose hydrogen breath test is used to diagnose the small intestinal bacterial overgrowth. So here again, the same thing, 20 parts per million, but glucose is better than lactulose because lactulose produces an intestinal hurry. So it can produce false interpretation. So we use glucose. So this is a glucose for small intestinal bacterial overgrowth, the terminology called SIBO or SIBO. So this is normal, whereas here, by about 15 to 30 minutes after swallowing itself, there's a rapid exit from the stomach, and this glucose is malabsorbed, so about 20 parts per million. So you have more things, tests required to confirm the etiology: endoscopy, jejunal aspirate culture, intestinal biopsy, radiology, capsule endoscopy, and then the power spiral enteroscopy, HIV serology and celiac serology are useful. So an endoscopic inspection of the intestinal mucosa will give you a clue as to what is it. Is it Whipple's? Is it Crohn's? Is it lymphoma? Is it IPSID? Everything has got a specific picture. This is the scalloped duodenal borders, very classical of celiac screw. Okay, so you do a mucosal biopsy. So the mucosal biopsy can definitely show Whipple's disease. This is an interesting disease, not very often. We don't see, I have not seen even one case of Whipple's in my 33 years of gastroenterology practice. So it's extremely uncommon in India. So lymphangiectasia, this is A-beta lipoproteinemia, and this is lymphoma, and then this is IPSID, and that is a parasitic, This is Giardia lamblia. You see the flocks, multiples of Giardia here. And this collagenous sprue is also common in India. And then these are the caseating granulomas for tuberculosis, Crohn's. This is the Crohn's microgranuloma without, caseation, lymphoma, IPSID, and then of course a non-specific villus atrophy because of all this tropical sprue and celiac. So mucosal biopsy can definitely establish these diseases and also, can suggest these, and non-specific atrophy can happen in these, so which cannot be helpful in a big way. So we can do imaging in malabsorption. So barium meal follow-through is discouraged. We don't do it at all. So we have to rule out pancreatic disorders and all that. See, look at this case, multiple jejunal diverticulae. Here bacteria can grow in the proximal gut and then can produce malabsorption. This is a case of Crohn's disease. You see this strictured segment. So malabsorption in specific disease states and the management, the tropical sprue, now it is less and less, but Professor Mathan from Vellore was the first one who showed the world in 1975 that an entity called tropical sprue happens because of recurrent diarrhea in villages. And but right now the tropical sprue is reducing a lot, but it's still there. So the etiopathogenesis is an acute infection which leads to chronicity. So and it forms acute infection, like even Campylobacter jejuni infection, can lead to chronic infection. It can be there for 3 months, and in the 3 months it can do a lot of damages to the intestinal mucosa, can produce enteropathy. And again, autoantibodies are formed against the vinculin in the vinculin, which is an antigen in the interstitial cells of Cajal in the small bowel, which alters the motility. So, sorry. So enteropathy happens because of chronic and acute infection, bacterial infection, which becomes chronic. And then there could be unidentified agents. So all these can lead to malabsorption. So there's an acute watery diarrhea, which gets forgotten, and then it becomes chronic diarrhea, and then it goes to overt steatorrhea and then leads to weight loss. So this is very typical. If there is a megaloblastic anemia, it favors tropical sprue. And microcytic hypochromic anemia favors celiac sprue. Okay. So you have to document by biopsy, and then you can give tetracycline 250 milligram 4 times a day, or a doxycycline 100 milligram once a day for 3 to 6 months as antibiotic charge, and folic acid supplementation. So MCTs may be better. So this is topical sprue before treatment. After treatment, see the villi have come up. This ironed out villi have all come up. So intestinal infection, I told you about all this. Apart from that, the parasites, Strongyloides petroralis and Capillaria bacteria, and then mycobacteria also, like tuberculosis, MAP, Mycobacterium avium. Intracellular paratuberculosis is thought to be an organism involved with Crohn's disease. We have analyzed 30 of our histopathology specimens in Crohn's disease. We did not find even one MAP, which is a paper getting published next year from multi-center study also from India, pan-India. It's also coming. That we don't see MAP in India, but there's something else happening in Crohn's in India. Giardia is one of the commonest, I told you. So this is the Giardia lamblia parasite. So, can I request people to mute their mics so that there is no disturbance? Please mute your mics. And the treatment of Giardia, I wouldn't spend time on it. What is small intestinal bacterial overgrowth is the SIBO. So this is, see, normally we have a lot of normal bacteria in the gut, but when it becomes abnormal, the numbers are more and the pathogens are there, then it is SIBO. So I'm just skipping for want of time. These are all the etiology of SIBO. So small intestinal bacterial overgrowth patients with abnormal bacteria, how do they present? They present with pain, discomfort, bloating, distension, diarrhea, flatulence, and weakness, just like any malabsorption guy. So when there is weight loss, steatorrhea, and fat-soluble vitamins are deficient, B12 deficiency, iron deficiency, folic acid is high. That is why Indians have always high folic acid. You don't need to supplement folic acid for Indians because this is synthesized by the bacteria, not by our gut. And then there is hypoproteinemia, hypoalbuminemia. So this is the SIBO, our data 2018 to 19. So we just took 154 patients with chronic or recurrent diarrhea with dyspepsia. We did a jejunal aspirate culture. We found that about 31 plus 43 plus 11, about 80% of our chronic diarrhea guys had SIBO. So these were all the organisms gram negative and gram positive. We just started doing the anaerobic culture also now in PGM. So all these bacteria can lead to this. We have an automatic, fully automatic system, which we draw the sample and within 5 minutes, it is seeded onto this machine, which is an automatic machine. So which also, there's another automatic machine. From there, we subculture, put it in. So 18 hours, we know the diagnosis, what bacteria and what it's sensitive to. So you have to rule out IBS. So I'm not going to spend time. And diabetic diarrhea also has to be remembered. And chronic diabetes, it could mean diabetic autonomic neuropathy. So diabetic neuropathy also has to be remembered.
Sorry, sir. Go ahead. Sorry.
Sound muted.
I think because somebody was.
Everybody was muted. Okay. So Uday Ghoshal gave the hypothesis that it starts as irritable bowel syndrome following an episode of acute diarrhea, which might have happened 3 months earlier. So it becomes a chronic diarrhea, and then it goes into IBS, and then goes into post-infectious malabsorption. I would bet that this is by far the commonest cause of malabsorption in India. So SIBO, how do you investigate? I just show you how to investigate. I told you. And what is the treatment? Again, tetracycline, norfloxacin, or you can use rifaximin. So you can give a 2-week course of 1,200 milligrams of rifaximin in a day for 15 days. So you can even repeat it after an interval. And the pre and probiotics are helpful because what I call the leaky gut hypothesis, where the intestinal mucosal epithelial tight junctions like claudin or cludin and all this desmoglin, all these become weak, so that there is a bacteria or the bacterial byproducts can cross the intestinal epithelial barrier. So this is called the leaky gut. So pathogenic bacteria can do this. Once you use prebiotics, which help in the colonization of probiotics, the probiotics can help in preventing the pathogens from producing the problem. So prokinetics can also help. This is a case of Crohn's disease, a patient where I did capsule endoscopy in 2009. We diagnosed aphthous erosion and also a curvilinear ulceration here. We told him to undergo, biologic therapy. He declined, and then he came back, and this is the next one. After 2 years, he had multiple strictures. So these are all strictures, and then he went in. The capsule couldn't go beyond. It got stayed there for more than 20 hours, but then finally came out, and then he had to undergo resection and anastomosis later on for Crohn's stricture. So this is the novel motorized power spiral enteroscopy, which we started this year. We are the first center in Tamil Nadu as yet, and we are one of the 4 centers in India doing this novel motorized power spiral. We can go deep into the small intestine, do all therapeutic procedures. This is a retained capsule done elsewhere, which we could retrieve using this. And this is that was the retrograde. This is the prograde, enteroscopy. So it can go very quickly. You can see how quickly the motorized power spiral enteroscope can go. Usually, you could never do a complete enteroscopic examination. Today, just within 45 minutes to 1 hour, you can reach the cecum from the mouth if there is no obstruction. And if there is a spot to which we reach, we do a tattoo. It's amazing. You can see the villi so beautifully. You can enlarge it. You can do all sorts of things. Here there is stasis. You see this portion in the ileum. There is stasis. So we go beyond, and we found that there is an ulceration and a stenosis there. This turned out to be Crohn's disease. So this is yet another case, a 28-year-old gentleman who came with anemia of 6.8, diarrhea, and this is what we found. The strictures and nodularity again turned out to be Crohn's disease. So progression in Crohn's can become like this. It starts like aphthous ulcers, then multiple aphthous ulcers, curvilinear ulcers, it goes to stenosis, and then this is a point of no return. So if you can diagnose, somebody comes with chronic diarrhea with pain, suspect Crohn's disease in youngsters today in India because it's on the rise. We have a 10-year VGM data. UC is stable, ulcerative colitis. Crohn's is on the rise. So you should diagnose Crohn's early so that treatment can be initiated to prevent fibrosis and stenosis. This is celiac disease. I've seen only one case, full-blown celiac, in a foreigner who came from Spain. So celiac is extremely uncommon. I'm skipping this because of the uncommon nature. And that was a dermatitis herpetiformis, so of celiac. Okay, so I'm just skipping through all this for want of time and not necessary because we don't have celiac here in Tamil Nadu. So IPSID, extremely rare, but we have seen one case of immunoproliferative small intestinal disease. This is from the atlas and this is from our patient. So we confirmed using our biopsy. And of course, vitamin B12 absorption can be checked by Schilling test. And diet, if it is celiac, you should avoid all the gluten containing foods. So an approach to a case of malabsorption, last 2 slides. So you have to achieve a specific diagnosis using the minimum number of tests possible in any given patient, which means that you have to do a head-to-foot examination, take a proper history. My teacher, Dr. Madana Gopalan, used to say, just keep listening, the patient will come out with the diagnosis. That is very important for anyone who is dealing with a GI case. Important that we have to do this. So choose necessary tests. If somebody comes with chronic diarrhea, do a detailed history and physical examination, do a screening test. And if it is all the screening tests are normal, rule out irritable bowel syndrome because it's an inclusion diagnosis today, and rule out colonic pathology by biopsies. And then you can go ahead further. If you find a confirmatory, particular disease, confirm it. If suspect a particular disease, confirm it. Then do the other screening test for celiac serology, mucosal disease or luminal disease. Then you can do a D-xylose test. And then you can do an intestinal biopsy, and various mucosal diseases can be established by biopsy. Then luminal causes by D-xylose or, all the breath tests, hydrogen breath test. And then you can try to intervene. So to conclude, my friends, malabsorption should be suspected in any patient with chronic diarrhea and weight loss. A careful history, a physical examination is vital. Remember the common causes in our own setting. Do not think celiac because it's there in All India Institute. Stool examination, mucosal biopsies, breath tests, and celiac serology at last will provide the diagnosis in most patients. Relevant tests based on clinical suspicion is the way to go. Clinical response to specific therapy once the diagnosis is confirmed. So I'll stop sharing my slides. I thank one and all of you for this very patient listening, and I gave only a bird's eye view of the whole malabsorption spectrum because it will require hours and hours because each topic is by itself is a big subject. Thank you so much.
Thank you very much, sir. It's a great feast of lecture of malabsorption syndrome. Actually, it's a very difficult topic to discuss in half an hour. And as a starting opening batsman, I think you have scored a triple century just like Sehwag. Even in between, you have some quick singles also, skipping many slides. It's really remarkable, and it's a very useful for the practicing physician as well as postgraduates. A lovely presentation, sir. I really amazed. And we do have our setup of small bowel endoscopy recently installed in our institution with the help of our Prime Minister's team. And we do our installing other lab facilities for diagnosing small bowel disease. And we want to have your advice regarding setting up of this breath test and all, so that it will be useful for the postgraduates. We have 2 postgraduates we have started this year. And it's an excellent feast, really. It's a remarkable one. I think it should be I will definitely will all the other people and here will be definitely agree with me. And thank you very much for here, sir. It's we want to have some more excellent feast in future also. Subramanian.
Yes, sir. Thank you. So thank you, Mohan sir, and also Dr. Kandasamy sir. So it's a nice presentation, as he was alluded to. So history is important, and we are also fascinated by the motorized enteroscopy. Yes, celiac disease is increasing nowadays. We also tend to see them. With regards to any questions, I haven't received any questions on the chat box. Perhaps we could allow one question because its time is already 7:30. Anybody wants to have ask question, please post. If not, we will have a big thank you to the speaker, Dr. Mohan Prasad from Coimbatore.
Thank you so much, and thanks to Professor Kandasamy and the entire team. And you're doing fantastic work in Tirunelveli Medical College. So you're an inspirational teacher, and you have fantastic physicians, who can inspire all of us. So very grateful, and all the very best. Any help from my side, I'll be always at your disposal, sir, to improve the quality and to add on new gadgets and to guide. I'll be very, very happy to do what little knowledge I have, I'll share. Thank you.
Sir. That's very kind, sir. Thank you.
Thank you, sir.
Thank you, Subramanian, sir. Bye.
Thank you, sir. We'll move on to the next topic.
Yes, sir.
Subramanian.
Next is Dr. Vijay Viswanathan, is the speaker, and Dr. Syed Sulaiman is the consultant physician from Tenkasi, who is going to chair the session. The topic is case-based discussion on diabetes and its complications. So, just a second. So, welcome to APA Tirunelveli and TUMC Medicine Update, Dr. Vijay Viswanathan. Sulaiman sir, please unmute.
In the interest of time, we'll cut the introduction.
Okay. So it's there, sir. So.
You can continue if
okay,
Sulaiman is not there.
Okay, so Vijay sir is well known in Tamil Nadu and all India, well-known diabetologist in a MV Hospital for Diabetes. He is a chief diabetologist and a president-elect for 2020, 21, 23 in Belgium Foot International, and RSD vice president nationally. You can see diabetes is equal to Dr. Vijay Viswanathan. So that's kind of interest, research, and also journal publication is, he was a former API state president, chairperson. I'm honored to welcome you, sir, for today's CME, which is in Tirunelveli. Welcome,
Thank you, Subramaniam. I'll finish in 12 minutes because we're running half an hour behind schedule.
Okay, sir.
Finish in 12 minutes.
Stop share so you can.
I'd like to thank Dr. S. Mohan and Dr. N. Subramanian for this invitation, and Dr. Allegation for this medicine update. I hope you can see the slide.
Yes, sir. Yes.
So what I'm going to do in the next 12 minutes is talk about 3 common cases in diabetes. And before I go on to the cases, we should understand many people think that complications of diabetes start several years after diabetes starts. It is actually not true. Even during the stage of pre-diabetes, which is about 5 years before the onset of type 2 diabetes, you can start getting macrovascular and microvascular complications. You can see this is the 0 point when it's diagnosed. I'll just put the pointer. So you can see this is the 0 point, but even much before that, the complications have started, microvascular as well as the macrovascular. So it's not that you should always get diabetes and 10 years of diabetes you will get. So I'm going to talk about, for the first complication is kidney and retinopathy, and I'm going to show you a case. And this is a study which we published in Indian Journal of Nephrology some years ago, where we looked at the cost of diabetes-related chronic kidney disease, and we found that it's very, very expensive to undergo dialysis. Transplantation is even more costly, and many patients are not able to undergo transplantation. Therefore, this patient who came to us about 6 months ago was a 52-year-old woman. So it's a woman, it's not a woman. Sorry for that. With history of type 2 diabetes for about 6 years. So it's fairly short duration of diabetes. But as I said in the previous slide, she must have had diabetes for at least 2-3 years, or a complication was earlier, with no past history of hypertension. She was quite obese, overweight. Her blood pressure was raised. She was not a known hypertensive. Her EGFR calculated by the CKD EPI formula. We don't do creatinine anymore. We do EGFR, because even before the creatinine goes up, the EGFR can start falling. And there was traces of albumin in the urine, which shows that the glomeruli are leaking. The LDL was raised. All the other lipid parameters were normal. ECG did not show any ischemia, but it showed a typical LVH pattern, which showed that she had hypertension for quite some time. And when we looked at the retina, it showed non-proliferative diabetic retinopathy. Her HbA1c was 8.9. She was already on glycoside 80 milligram BD and metformin 1000 milligram BD, not on any other medication, just these two. Now, people might say, if you ask them, this is the diagnosis, type 2 diabetes with diabetic kidney disease, quite evident, because you can see that the person has albumin, a drop in EGFR, and retinopathy. If you have these three features, you can say that the person has got diabetic kidney disease. If you don't have albumin, if your EGFR alone drops and there is no retinopathy, then comes a problem. It could be a non-diabetic kidney disease. So this is a classical diabetic kidney disease with diabetic retinopathy, with LVH, which means she had hypertension for quite some time, and dyslipidemia. Therefore, the next 2 minutes, let's see about how we should manage diabetes. Now, many people might say that when you talk about the management of diabetes, they'll say add a gliptin. Some people might say start insulin, because basal insulin, because the patient already has retinopathy and so on. Therefore, we will see in the management of diabetes what we should do. Now, some years ago, about 21 years ago, we showed that there is a very strong genetic component for diabetic nephropathy in type 2 diabetes. And we showed that this particular gene, ACE gene polymorphism on chromosome 17, if you have that, and along with colleagues from the United States, we showed that there is a very strong association between the ACE gene polymorphism and diabetic nephropathy. But there is a very, very important role to manage diabetes. And for that, we have this latest guidelines from the ADA, which says that if you have a patient like this, an elderly woman who's obese, who's overweight, and who's got established atherosclerotic cardiovascular disease. She's got hypertension, she's got dyslipidemia, she's got LVH in the echo and ECG, and she also has microalbuminuria. Therefore, she has a classical atherosclerotic cardiovascular disease, and a CKD has already started. So in such individuals, over gliptin, over insulin, there might be a help in using a GLP-1 analog or an SGLT2 inhibitor. This is what this patient deserves. She requires an SGLT2 inhibitor, and SGLT2 inhibitors like dapagliflozin, canagliflozin, you can use any of them. I don't think there's hardly any difference between EMPA and Cana and so on. And in addition to increased glucose reabsorption, and increased glucose reduces reabsorption, so includes glucose excretion and increased sodium excretion. It produces a drop in blood pressure, which this lady needs. She's quite obese, so she needs quite modest weight reduction, which will be provided. And you get a HbA1c drop of 1%. She had 8.9, so you will get a good HbA1c reduction. In addition to the effects on the kidney, you can also get effects on the blood vessels and also on the cardiac tissue. Therefore, this is what this lady needs. So to go back to the case, this lady she has glycoside, she has metformin, and in spite of that, her HbA1c is 8.9. So probably you should have an SGLT2 inhibitor. And this was probably the classical study, the EMPA-REG, which was done by Bernard Zibman from the United States, where they had about 7,000 patients. You can see that they had all these comorbid conditions. They had diabetic nephropathy. They were already on ACE inhibitors, they were on statins. And by giving SGLT2 inhibitors like empagliflozin, they got a substantial reduction in the primary outcome, CV death and total mortality. Therefore, I think it's very important to consider in such patients who have diabetic kidney disease, who have atherosclerotic cardiovascular disease, to consider the addition of an SGLT2 inhibitor. Of course, this lady had not started any antihypertensives. Definitely, this should be the target, and you should add an ACE or an ARB. I don't think there's hardly much difference between an ACE and an ARB. We have data for both ACE and ARB in diabetics. Of course, retinopathy is one which is often neglected. Patients say that they don't need a fundus examination. They say that they had the refraction, which is quite okay, but you should detect the maculopathy, which is quite common in such patients, and treat them with green laser, which will help to prevent blindness. And of course, you need to add statin. This lady had not started statin. The second complication I'm going to is preventing an amputation, and that will take about 2 to 3 minutes. Now, we have this unpleasant situation where people lose their legs. This was a bus driver who lost his leg and lost his job. This was a tailor. He lost his job and he lost his leg, and so on. And we should understand that there is a stage of normal foot and a high risk foot, where you have diabetic neuropathy and peripheral artery disease, which is often not diagnosed. Therefore, as physicians, as diabetologists, we should screen people and try to detect people with diabetes in stage 1 and stage 2 when they have a normal feet or they have a high-risk foot. After ulceration infection starts, there is very little we physicians or diabetologists or endocrinologists can do. But this was a 60-year-old lady who came with peripheral arterial disease and damage to the left ankle, an infected wound here with necrotizing fasciitis, with cellulitis. So she had been advised a below knee amputation. So this was a classical case where first you do a debridement and go on to do a second debridement, and the ankle joint is exposed. You can see the ankle joint is all exposed. And she had peripheral arterial disease. So she first requires a peripheral bypass surgery, a femoral popliteal bypass, or an angioplasty to the posterior tibial or peroneal artery or whatever. And then she needs the orthopedic surgeon to come in. This is done by a vascular surgeon. And then she needs a orthopedic surgeon to come in and put in what is called an Ilizarov ring or an external fixator to fix the ankle joint. And then she has VAC therapy, vacuum assisted closure. She has hyperbaric oxygen and so on. And finally, the plastic surgeon puts a skin graft. Therefore, we have beautiful technologies in India for the last 10 years, the negative pressure wound therapy, which can save a lot of amputations. As you can see, this lady had a negative pressure wound therapy also done. And also hyperbaric oxygen after a peripheral revascularization like bypass or angioplasty can help the collaterals to open up. Therefore, hyperbaric oxygen is useful, especially after peripheral revascularization. Therefore, to prevent an amputation, what we need to do is a regular inspection and examination of the at-risk feet. So every diabetologist, physician, endocrinologist should examine the feet for peripheral pulses, for loss of sensation, for loss of the ankle jerks, and identify the at-risk feet. Having identified the at-risk feet, we should educate the patient, family, healthcare providers to wear the right type of footwear and avoid high plantar pressures. Appropriate footwear is important. And if the person gets what is called a callus, where you get a thick skin under the first metatarsal head, you should probably remove it off, debride it. And last 2 minutes, I would like to talk to you about a new perspective in tuberculosis and diabetes. This was a 35-year-old man who presents with a history of cough and fever since 2 months. This was before COVID, so we did not suspect COVID. He was on, this was somewhere last year, before COVID-19 had started. He was on glimepiride 2 milligrams per day. Okay, his HbA1c was 8.3. He was fairly well nourished. BMI was 27. Fasting blood sugar was not all that high, 145. The PP was 225. Therefore, there was no need of an absolute need for insulin in this individual. His X-ray showed a classical cavitary lesion in the right apex. So we start ATT as per the RNTCP guideline, and we add metformin. Metformin is always sometimes avoided in patients with tuberculosis. So what I'm going to talk to you in the next 1 minute is metformin is a new avatar as an anti-TB drug, because Amit Singhal from Singapore first published in 2014 that metformin has got an anti-tuberculous effect. So this was the first article which came out from Amit Singhal's group. And recently, about 2 years before, along with colleagues from the United States, we published this article where we looked at matrix proteinases in people who had diabetes and TB and diabetes without TB, who were on metformin. And you can see that certain MMPs, like MMP1, among those who took metformin were lower. MMP2 was lower. MMP7 was lower. You can see that certain MMP expressions were lower when they took metformin. So we still do not have prospective studies looking at metformin. But definitely, if you see a person like this, don't avoid metformin. If the person is vomiting and is emaciated, maybe you should not start metformin. That if the person is well nourished, you should think of adding metformin along with glimepiride. So I think these are 3 messages which I wanted to give you. And I would like to thank Dr. A.S. Mohan and Dr. N. Subramanian and Dr. Alagason for this invitation. Thank you for your attention.
Suleiman sir, are you there?
Yeah.
Please, sir. We missed you earlier on, so go ahead, sir.
Okay. Thank you, Dr. Vijay Vishwanathan. It was a very wonderful description about 3 cases. As we have rightly said, most of the diabetic patients, they walk, those who have ulcer, they walk to their grave by their foot. So a diabetic foot is a prelude for amputation. So the best thing is to avoid getting a diabetic boot or diabetic foot. So it's imperative for any physician to check for the pedal pulses and for the sensation in all the patients, especially diabetic patients who come to them. It was very wonderful, very short and sweet message you have given. And I think there are some questions in the chat box. Dr. Subramanian, are you going to take?
Yes, sir. I shall. So this is from Dr. Arul. Diabetes with Charcot arthropathy. What is the recommended management?
So there are 2 types of Charcot you should keep in mind. One is an acute Charcot, where the patient comes to you with a acutely swollen foot. Now, in this patient, you should not allow him to walk. You should put a TCC. You can give him bisphosphonates and make him take bed rest for 3 weeks. Now, if the person has got a chronic Charcot, patient will come with a swelling, with collapse of the mid region of the foot, the midfoot, and with a flat foot, and with a rocker bottom foot. This is chronic Charcot. Now, here you can be a little more less aggressive and make him walk with a special boot which will reduce the pressure under the midfoot, and so on. So Charcot foot depends on what you're facing, an acute Charcot or a chronic Charcot. So I hope that answers the question.
Okay, sir. Thank you. So next question is, do metformin score over insulin in terms of improving immunity, especially with regard to that patient you described?
Yeah, so there is no studies which have said insulin is better, metformin is better, glimepiride is better, glimepiride is better. And we found in the study called EDOTS, Effect of Diabetes on Tuberculosis Severity, which we did in Chennai under the Chennai Corporation about 5 years. We followed our patients 1.5 years after they finished their ATT under the RNTCP. We found that diabetes control is not at all important in the outcome. We found that it was body mass index and nutrition below 18 BMI which was influencing the outcome of the TB. The HbA1c, even if it was more than 8, if they were having good nutrition, BMI, the outcomes were good. So there is no study which shows insulin is better, metformin is better, but metformin has got a definite TB effect. It's got a host-mediated response like verapamil, like metformin, is being tried out in TB. And the government of India might include metformin as part of the cocktail for tuberculosis.
Thank you. Thank you, sir. So the last question will be, can SGLT2 inhibitors given in this COVID season for fear of DKA?
So I don't think there is any connection between SGLT2 inhibitors and COVID.
No.
The moment you're diagnosed with COVID, we're not going to give SGLT2 inhibitors. But no study has shown that SGLT2 inhibitors will predispose somebody to COVID, not at all. And it'll give you good control of diabetes, which is what you want. At the time of getting COVID, your diabetes should be under control. So there is absolutely no problem in giving SGLT2 inhibitors, gliptins, metformin, insulin, sulfonylureas, anything during this COVID era. There's absolutely no problem.
Thank you. That was excellent, sir.
So I have one question. In non-infective neuropathic ulcer, do you suggest any specific type of dressings or growth factors for wound healing?
Good question, sir. So if you have a ulcer, neuropathic ulcer, which is not ischemic, and which is in the head of the first metatarsal head, and which is not healed even after 4 weeks of conventional treatment of offloading and so on, you can use the growth factors. And the only one which is available in India right now is the epidermal growth factor. The platelet-derived growth factor is not available, Plurmin. But what is available is Region D from Bharat Biotech, who's also doing the COVID vaccine. So they have what is called an epidermal growth factor, which can be applied to a neuropathic ulcer, which is not healed even after 4 weeks of offloading and all that. It heals beautifully. We have published a paper in Wounds in 2007. So it cuts down your healing time by 40%. Therefore, I think the epidermal growth factor is definitely useful in people who have a neuropathic ulcer, not an ischemic ulcer, not an infected ulcer, but a neuropathic ulcer which is not healed even after 4 weeks, because it's quite expensive. It costs about 1,200 rupees for one tube of 100 grams. Does that answer your question, sir?
Yeah, thank you. Dr. Subramanian, there is no question. I think you can.
You're muted. Yeah.
Sorry, yes. Yeah, I'm unmute. So we don't think we have any more questions. So that was lovely talk, sir. So once again, on behalf of organizing committee, I thank you for your time on a busy schedule. I also thank Dr. Sulaiman, sir, for coordinating this program. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you. So next will be Dr. Chenniyappan's talk. So he's a famous cardiologist from Trichy. Dr. Ravi Edwin, who is the HOD of Cardiology of Medicine, is going to chair the session from TVMCH. So this is the program for today and tomorrow. I hope you can all see the slide. So we have 4 topics today, and we'll have remaining 4 topics tomorrow, and also a PG quiz program tomorrow. So please post your details for CME credits. We do have, and the APA Tirunelveli will pay for your CME credits. And if you don't have full information, I'm afraid it's difficult to send, because it won't approve the CPD points in your name. And any questions also post with your name in the chat box. That will help us to discuss during the discussion. So it will be, the topic will be on STEMI, dilemmas in STEMI. So, the era has gone from thrombolysis to nowadays to cath lab. All are going for primary PCI. So Dr. Ravi Edwin, sir.
So participants are requested to mute their
Yes, I have done that now. Yes.
audio.
Yes, sir. I have done for some of them. So, his name is not there unless he is gone. He's got to a different.
As per program, it is 8 o'clock.
Yes, sir.
That's why he'll be joining within 2 minutes.
He is picking up the phone, but he's not able to talk.
Yes, his voice is not audible, sir, on phone also.
Right. So it's probably stuck in ICU somewhere. And Dr. Dinakaran is joined, who is the subsequent speaker. So there are, being a weekend, there are many CMEs and webinars happening. So I'm grateful to all the participants here who have been here since 6 o'clock. It's about 180 participants as of now. So it's all for everybody's benefit in this time. So we asked our chairman, sir, to talk to the next speaker. Just to share with you that this is going live on YouTube, and we also are recording for people who had to move out, so that you can listen to the recordings back again.
Hello.
Yes, sir. Yes, sir.
Jennifer sir will talk in the next.
Okay. Okay. So we'll talk to Dr. Dinakaran sir then. Dinakaran sir
is there. He was there from the beginning.
Yes. Yes. Dinakaran sir.
Hello.
Yes, Dinakaran sir.
Yeah. Can you hear me?
So yes, sir. So are we okay?
I'm okay, but
if you are,
maybe I need to upload the slides and my
right.
talk comes. share the slides. I will share screen.
Okay, sir.
Switch over to the slides. Is
Okay,
that
okay. Yes, sir. Definite. So, Dr. Ram Subramanian, sir, are you in connection? I'll try to unmute. Ram Subbu, sir.
Hello. Dinakaran sir talk ஆரம்பிச்சிட்டு அவரு சென்னிப்ப சார் அடுத்தது.
Okay, I'm ready.
Very good, sir. I'll just see whether the chairperson.
இப்போ திடீர்னு அவர் சென்னிப்ப சார் பேச வேண்டியது அவர் வரல. அடுத்ததுதான் அவர் 8:45 கொண்டாரு. ஸ்டார்ட் பண்ணிட்டுமா ஜாயின் பண்ணணும் இல்லையா? இல்ல டைம் அவர் தினகரன் சார் பேச ஆரம்பிச்சிட்டாரு. விட்டு பிறகு எவ்வளவு நேரம் ஆகும்? அப்படியா? அப்போ ஆரம்பிச்சிடறோம், நீ அதுக்கு ஜாயின் பண்ணிரு. 30 minutes. Subramaniam.
Yes, sir.
You can start. He will join after 10 minutes.
Okay. So next will be Dr. Dinakaran, who is the Director and Chief Nephrologist in Madurai. You all know him. So he was the pioneer in nephrology in Madurai Medical College. And he has established dialysis and transplantation center in Madurai and also separately as Madurai Kidney Center. So he has got innumerable publications under his name. He's quite passionate about reach and read. These are community-oriented programs to prevent acute kidney injury. So he's going to talk on what's new in chronic renal failure management with the current perspective. So I'm warmly welcome Dr. Dinakaran, who is going to talk on this topic over the next half an hour. Welcome, sir. And thank you for coming early also before your time. Thank you. Over to you, sir.
Then maybe now I'm audible, no?
Yes, sir, you are.
You can see my slides also?
Indeed, yes.
Okay. Can I go ahead?
Yes, sir, please.
Are you going to hand over to the chairperson? Are they going to say any comments now?
Chairperson is on the way, so I have introduced you. So he will join in a few minutes. You can start.
So I will start.
Yes, sir.
Maybe just a minute.
Yeah, no problem.
I have chosen the wrong slide.
It's a different PPT.
Unable to hear, sir.
I think Dinakaran sir has muted.
No, I think what he is doing is he's getting this current. Yeah, he's.
Okay.
Yeah.
Are you able to see the screen?
Yes, sir. Yes. Correct slide. Yeah.
Yeah. So
very good.
You can hear me also.
Very good, sir. Welcome back.
Okay. So the topic is as given by the APA Tirunelveli. I'm thankful to them for inviting me to take part in this program. What is new in CRF management? Everybody knows that the term CRF has now been changed to CKD, but still stage 5 CKD may be called as maybe called as CRO. Why the terminology was changed was because CKD denoted a wrong idea in the minds of the people that it is failure of the kidney to function. So International Society decided to call it as chronic kidney disease and introduce the staging to identify the different levels of kidney function. So death from CKD has increased in the past 20 years or so phenomenally. This is a global phenomena, and if you look at the Indian scenario, it's the same. But compared to the phenomenally high incidence of CKD, the population, CKD around 16.8% of the population, at some stage or other. It does not mean that it is stage 5 CKD, it may be stage 1, 2 or 3. Only 0.15% of this population can afford renal replacement therapy. The Indian scenario is not different. You have in CKD 4 and 5, nearly 7%, 1 and 1, 9% in stage 4, and another 7% in CKD stage 5. And when you look at the management being offered to them, majority of them, 3/4 are being managed conservatively. The dialysis, maintenance HD, or even transplant, everything is offered to less than 20% of the population. This is almost a global phenomenon, not only Indian, but this is the Indian statistics. So, in managing CKD, the most important thing appears to be managing them conservatively and preventing them from reaching the stage of either stage 5 CKD requiring dialysis or developing a cardiac problem and succumbing to it. So that is the primary duty of a physician. This has to be done at the level of the physicians. Primary care professionals or physicians play a significant role in early diagnosis, treatment, and educating the patients. The emphasis is on detecting CKD as early as possible and managing it efficiently before referral at the later stages of CKD. So I would like to stress that CKD is part of primary care, and primary care providers are the first line of defense against CKD. So what shall we do to screen CKD and evaluate them? What is required are only 2 tests. One is estimating the eGFR. This was also pointed out by Dr. Vijay Vishwanathan. We do it from creatinine only, but using the formulae that are now available from the International Society of Nephrology, we calculate the estimated glomerular filtration rate. It is considered to be the best overall index of kidney function, and normal GFR varies according to age, sex, body size, and declines with age. So these parameters are given weightage in deciding the estimated glomerular filtration rate. The NKF recommends using the CKD-EPI, that is the currently accepted formula to be used for doing estimated GFR. And GFR calculators are available at various resources. You can easily calculate using them. The second most important screening tool is the albumin-creatinine ratio. One side you estimate the creatinine and calculate the eGFR. The other most important screening tool is estimation of the urine albumin and comparing it with the urinary creatinine excretion. This is done because the albumin level can modify due to the diluted urine or concentrated urine or reduced glomerular filtration rate, reducing the protein leak, etc. So to overcome all these modifying factors and to arrive at a proper measure of the protein leak from the kidney, the ACR, the albumin creatinine ratio, is the one that is currently used. So today's evaluation, screening of CKD and prognostication of CKD depends on these 2 parameters. And this is the diagram or the heat map that is generated, that is given to us On one side, we have the glomerular filtration rate based EGFRs, creatinine based EGFRs. Based on that, we divide them into different grades. On the other side, you have the severity of albuminuria, and only when you combine both, you know how severe the problem is. For example, even if EGFR is between 45 to 59, that is G3A, if the protein leak is more than 300 milligrams, this is a dangerous situation. The chances for progress, the chances for cardiac mortality, and the need for RRT are higher. So this is the heat map, which shows that you have to depend on both the EGFR and the quantity of protein that is excreted to decide how severe is the issue and how effectively it should be managed. And once you assess, evaluate, screen, and find out the severity of the issue, in whom it should be done. It cannot be done for all the population at all times. So we use what are called as the susceptibility factors. A person with diabetes, with hypertension, especially if the duration is more than 5 years, older age, family history of CKD, racial or ethnic minority, and the other low-income, minimal education people, and kidney mass reduction, ultrasonography, you have contracted kidneys or one kidney is contracted. These are all the susceptible groups where we have to work out. Once you identify that somebody has CKD, what are all the factors that contributes to the progression? Severity of proteinuria, uncontrolled BP, glycemic control in a diabetic, smoking, hyperlipidemia, CVD and anemia, and altered mineral bone disorders are the complicating factors. So these are the problems that we have to tackle. Our goal today is to maintain a person conservatively. And the goal is to slow down the decline in kidney function. The priority goes for blood pressure control. As you know, when the albumin creatinine ratio is rather low, a little higher level of BP target can be allowed. ACR less than 30, a BP of 140/90, ACR 30 to 300, BP of 130/80. The albumin creatinine ratio is more than 300 milligrams per gram of creatinine. That means that there is a significant nephrotic range proteinuria. The target BP has to be 130/80 millimeters of mercury. And so based on these factors, the age, the activity of the person, whether he is a diabetic, whether he has coexistent cardiovascular disease, we'll have to fix the targets and try to achieve them. The mainstay in controlling BP in this category is by using ACE and ARBs. How do we slow the CKD progression with ACE and ARBs? We have to, risk benefit should be assessed, check labs after initiation. Once you start somebody with CKD with proteinuria on an ACE or ARB, within say about 3 weeks or so, check the creatinine. If the fall is more than 25%, go slow or try to reduce or even stop the drug unless it is warranted continuously. If the slope is more than 25%, you evaluate for other factors. Another factor that should be looked into is hyperkalemia. When hyperkalemia complicates treatment with ACE and ARBs, look for other causes for hyperkalemia, dietary factors, use of beta blockers, use of NSAIDs, potassium sparing diuretics. Try to stop all that and try to continue the RAS blockade because that gives the long-term protection. So the other contributing factors like dehydration, volume depletion, overuse of diuretics have to be withdrawn if you want to avoid hyperkalemia. The risk of adverse events are there with ACE and ARBs, but if it is used judiciously, no level of creatinine is a limitation for using ACE or ARB. Similarly, when you talk about glucose control, the target HbA1c is between 7 to 8%. It can be extended above 7 if there are other comorbidities, as it is today followed in even diabetes management. Remember that hypoglycemia risk goes up if the CKD worsens. Declining kidney function, we may have to modify certain OHAs and also modify the dose of insulin. This has to be kept in mind. Now we go to the other areas which tend to complicate the progression or rather worsen the CKD scenario. Anemia is a very important contributory factor. Anemia not only causes left ventricular hypertrophy, cardiac stress, it also hastens the rate at which kidney failure progresses. So we'll have to initiate iron therapy when the ferritin levels go down, when the serum iron levels go below 100 nanograms per deciliter, and we will have to follow them up and use erythropoietin judiciously. By that I mean, without correcting iron deficiency, using a costlier drug like erythropoietin may not be very efficient. So we'll have to do that before using erythropoietins to correct anemia. And this mineral and bone disorder, the hyperphosphatemia, the hypercalcemia, the hyperparathyroidism, rise levels of FGF3, these are all the factors that contribute to not only bone resorption, osteomalacia, osteopenia, but to vascular calcifications, higher cardiac mortalities, and the sequelae of CKD, which even precede the progression of CKD. So managing the mineral bone disorder is an important aspect of managing CKD. The importance given to hyperphosphatemia has been stressed again and again. It is the hyperphosphatemia that is the initial provoking factor for the increased cardiac mortality, the resultant hypocalcemia, the rising PTH levels, and also FGF3 levels. So phosphate binders do play an important part in the management of CKD. We have shifted from calcium-based phosphate binders to sevelamer-based calcium binders, phosphate binders. Newer phosphate binders like Tepanor are now in the pipeline, have not yet reached the global practical usage. So the mineral metabolism goes through a vicious cycle and leads to the problems like vascular calcification, arterial stiffness, impaired LV function, and these contribute to a higher incidence of heart failure and ischemic disease in CKD patients. I will touch upon the newer advances on two aspects. One is anemia, the other is the diabetes and kidney. What are the newer developments in the management? One, in anemia therapy, instead of relying more on oral irons for a very long period, especially with advanced CKD, we today prefer to use IV irons because that helps to replenish the iron stores quickly. It remains in circulation for a long time and helps in improving anemia with the use of erythropoietin stimulating agents. Erythropoietin stimulating agents, when they were initially introduced about 20 years ago, were very costly. But now with technical advancement and biosimilar products coming, the rate has come down and it has become affordable. So it has to be used in people in whom iron deficiency has been corrected and still they continue to be anemic. Erythropoietins have to be used. Dialysate iron is a current advancement. That's something that is in development and not yet fully reached the practical scene. The most important discovery in the management of anemia today appears to be what are called as hypoxia-inducible factor stabilizers. I'll just explain this a little. These hypoxia-inducible factors are produced from the kidney whenever there is a hypoxia in the kidney. How does that happen? The iron studies, as I was telling earlier, a higher dose of iron given at periodic intervals goes a long way in correcting anemia of CKD. Coming back to HIF stabilizers, hypoxia-inducible factor stabilizers. Hypoxia-inducible factor is generated from the kidney in response to hypoxia in the kidney, and this is immediately destroyed by the enzyme called prolyl hydroxylase. So what we need is to inhibit the prolyl hydroxylase. So inhibiting HIF proline hydroxylase will result in stabilization of the hypoxia-inducible factor. So they are indirectly called as hypoxia-inducible factor stabilizers. These are still in the experimental or the therapeutic stage, has not yet been reached. Anemia in CKD is multifactorial. The hypoxic response is dysregulated. The required amount of hypoxia-inducible factor is not generated. And there is a reduction in erythropoietin production. Chronic inflammation can cause defective release of iron from the stores. Uremic toxins may cause anemia, iron deficiency, blood loss, shortened RBC lifespans. Another important factor seems to be hepcidin. This hepcidin is released from the liver and it prevents iron absorption, prevents iron mobilization, and plays a negative role in correcting anemia. So it has to be suppressed if you want to really get a good response to your treatment in correcting anemia. Erythropoietin is a hematopoietic growth factor, primarily in the kidney, and healthy kidneys adapt to the changes it senses in the oxygen content. Either due to hypoxia respiratory or due to severe anemia, there is not much RBCs to carry oxygen. And so, by increasing the number of erythropoietin producing and oxygen sensing cells in the tubules of the kidney juxtamedullary cortex. So, remember this terminology, the role played by renal erythropoietin producing and oxygen sensing cells, short called as repose cells. These play a very important role in correcting anemia or causing anemia, either normal kidney or in diseased kidney. And the repose cells account for 90% of the erythropoietin synthesis. The remaining 10% may come from the liver. So how does it happen? Sensed changes in renal tissue oxygen levels regulate erythropoietin production. How is it sensed? Rate of RBC production is adjusted by regulation of erythropoietin produced in the kidney. And that is produced by hypoxia stimulating new RBC production through increased production of erythropoietin. And erythropoietin acts on the bone marrow to release the mature RBCs into the circulation. The repose cells in the kidney, I said the renal erythropoietin and sensing cells in the kidney continuously sense oxygen levels and regulate the activity of hypoxia-inducible factor. As you see here in the tubule, you have the tubular epithelial cells normal, and certain cells have got the capacity to act as renal erythropoietin and oxygen sensing cells. These are the ones. And those cells will release the erythropoietin in response to the hypoxia-inducible factor stimulating them. So repose cells are interstitial fibroblast-like cells, and activation of hypoxia-inducible factor that acts as a transcription factor induces expression of erythropoietin and similar genes. So what we have to remember is that the anoxia, reduced oxygen delivery to the kidney, is sensed by the kidney by the cells called as the repose cells. They, through a transcription factor called hypoxia-inducible factor, stimulate the erythropoietin release. So hypoxia-inducible factors coordinate a series of responses to hypoxia and regulate erythropoiesis. Activation of the HIF pathway synchronizes with increased erythropoietin production, which results in upregulation of iron absorption. So these are the important steps in the formation of RBCs and correction of anemia. In addition, these can produce adequate amounts of erythropoietin normally, but what happens in CKD? There is a reduction in the number of these repose cells. Most of these cells get converted to myofibroblasts. Once they become myofibroblasts, they lose their effectiveness as renal erythropoietin producing and oxygen sensing cells. So this is what happening in CKD with injured renal tubules and interstitium. So there is an irreversible change. There is a reduction in repose cells, reduction in HIF levels, and a reduction in the production of erythropoietin, all contributing to reduced RBC mass or anemia. So in CKD, there is disruption of oxygen sensing mechanism that prevents HF pathway activation and leads to lesser levels of erythropoietin and anemia. The HIF stabilizers experimentally and which have crossed through phase 3 trials also and awaiting approval, important ones are the roxadustat, vadadustat, and daprodustat. They have got different pharmacokinetics, but we'll know more about it as and when they reach the practical scenario or practical usage of them. There was a lot of worries that these things which stimulate RBC mass in a high way may lead to cardiovascular safety problems. But studies with them in dialysis patients or non-dialysis patients have shown that it doesn't add to the cardiac morbidity or mortality. And other benefits are, it has a role in slowing the eGFR decline, even in the non-dialysis dependent patients. It improves the quality of life as it happens with correction of anemia. It also has a role in correcting the inflammatory status of CKD, which goes a long way in preventing atherosclerosis, ischemic heart disease, and also iron depletion. It helps to some extent in reducing cholesterol, reducing hepcidin, and blood pressure also. So to conclude, the HIF stabilizers are the future promising ones which are going to be useful in the treatment of anemia, and they will replace erythropoietin stimulating agents in people who are erythropoietin resistant, especially with the high inflammation, high ferritin levels. Many of the anemic patients of CKD do not improve with erythropoietin. But what will be its cost? Time alone has to answer. And the long-term stabilizers have some issues like angiogenesis, increased matrix production, and pulmonary hypertension. And these will have to be followed in due course of time before we know more about them. Then, going back to the other problems. So anemia is one area which is playing a very leading role in causing the symptoms related to CKD, causing the higher cardiovascular changes that occur in CKD, and also contributes to progression of CKD. There is some light at the end of the tunnel for anemia management with the HIF stabilizers. Going back to the other areas which have to be tackled in slowing the progression of CKD, one is metabolic acidosis. Usually occurs later, and the correction of metabolic acidosis has been shown to slow the progression and improve the patient's functional status. Hyperkalemia is another issue in CKD, which can come in stealthily and produce very devastating results in the form of sudden cardiac death, etc. So we have to be all the time follow these patients while on treatment for their potassium levels. Metabolic acidosis, bicarb therapy has come to stay. We are using it whenever the bicarb level is less than 22, or absolutely when it is less than 18, there is a definite indication for use of alkali therapy. When you are using alkali therapy, monitor the fluid retention, its effect on hypertension, and whether it is able to correct the serum bicarbonate levels as you treat them. If you are able to treat metabolic acidosis with sodium bicarbonate without contributing to volume overload or worsening of hypertension, you have done a good job, and it helps in slowing down the rate of CKD deterioration. And there are some newer agents in the pipeline. This is a TRC101. It's a promising medication which is found to help in metabolic acidosis with CKD. It's a sodium-free hydrochloric acid binding agent. It raises bicarbonate by 45%. It acts by selectively binding hydrogen ions and chloride ions in the gut. And this will remove hydrogen ions and chloride, result in increase in serum bicarbonate. This is something again which is under development, and when it is available and has passed through the third phase trials, we will hear more about them. So that is another area where some advances is happening. Coming back to the last part, diabetes and CKD, as we know, diabetes as a leading cause globally, and in India, it contributes to 30 to 40% of cases of kidney disease. And if you look at the Indian data, the diabetic nephropathy is around 30.9% incidence. CV disease and kidney disease are prevalent in patients with type 2 diabetes mellitus. Patients with type 2 have twice the risk of CV disease, and 50% of type 2 diabetics beyond 5 years of diabetes have nearly 50% renal involvement. The prevalence of CKD parameters, CKD based on KDIGO, overt CKD in type 2 diabetes mellitus with a GFR less than 60 seen about 21.7%, and a GFR less than 90 in about 64.7% of type 2 patients. this context, a breakthrough has been seen within the past 10 years. The SGLT2 inhibitors, which were introduced as weak anti-diabetic agents, by field trials have shown that they have got a predominant cardiorenal protective effect. And today, this cardiorenal protection seems to overtake its hypoglycemic action also. We'll just see some details about this. Kidney disease is a strong risk factor for mortality and due to even diabetes alone. If you look at diabetes alone, all-cause mortality is around about 18% or so. In a person with previous MI, it's quite higher than that. If you have a person with CKD, then the incidence goes above nearly 40%. If you look at a person with diabetes and CKD, the risk for cardiac mortality is around 70%. That's why a diabetes with kidney disease has to be looked with a lot of caution. The diabetes causes proteinuria and leads to glomerular hyperfiltration by this glomerular hyperdynamism. What does it happen? When there is SGLT2 acting, it absorbs glucose and sodium. And so as a result, the less amount of sodium is delivered to the distal tubule. And that is sensed by the macula densa as a condition requiring increase in GFR because it wants to excrete more sodium. So the macula densa releases adenosine and similar products, which modulates the afferent arteriole and causes a little afferent arteriolar dilatation. And this is an attempt to improve the glomerular hypertension and the glomerular filtration. So that will result in increased GFR. This is what happens normally in a diabetic. But when you have an SGLT2 inhibition, SGLT2, which acts at the proximal complement tubule, if it's inhibited by an SGLT2 inhibitor, we have taken empagliflozin as the example. When this SGLT2 inhibitor reaches its site of action, proximal convoluted tubule, then the glucose is not reabsorbed along with the sodium. Both glucose and sodium reach the distal tubule in a higher concentration. They are sensed by the macula densa. They feel that already there is high sodium filtration. The GFR may have to be curtailed. And that releases substances which will again cause afferent arteriolar reduction in size. You saw previously the afferent arteriole was dilated. Now the glomerular pressure has come down, the afferent arteriole has reached its normal level, and there is a reduction in GFR. So this is what we are able to achieve with the SGLT2 inhibitors through hemodynamic mechanisms. But as more and more information is coming on SGLT2 inhibitors, there are a lot of other methods by which it is active. So the empagliflozin has a hemodynamic effect by modulating the afferent arteriolar dilatation that happens in diabetes. So with SGLT inhibition, we will be able to have a temporary reduction in glomerular pressure, but in the long run, it will lead to reduction in albumin loss and will also offer renal protection. Whereas ROS blockade also produced a similar effect. Reduced glomerular pressure, reduced albuminuria, and renal protection was achieved. So will it be complementary? It appears to be so. So when we combine SGLT2 inhibition and ROS blockade, maybe there will be a combination effect, and that will be very helpful in managing these diabetics with kidney problem. Another study, EMPA-REG, was the one which first threw light on this renal cardioprotection with SGLT2 inhibitors. A specific study looked at the high-risk renal patients. That was the CREDENCE study, which report was released in the 2019 International Society meeting at Sydney. It included a number of patients with severe renal involvement, people with the GFR less than 45 ml, and people with the creatinine, the ACR, albumin creatinine ratio more than 300. So this was a kidney-centric study with a DP, with canagliflozin. And the primary outcome showed that there was a definite reduction in the incidence of the hazard ratio with response to the renal outcomes in the form of end-stage kidney disease, doubling of creatinine, renal or cardiovascular death. There was a 30% reduction in these endpoints with canagliflozin. Similarly, when we looked at the renal points alone, doubling of serum creatinine or renal death, there was a 34% reduction in the outcomes. That was a beneficial effect of the canagliflozin on slowing the rate of renal deterioration. The forest plot, which combines both renal and cardiac, shows that for all parameters that have been analyzed, doubling of serum creatinine, end-stage kidney disease, falling of eGFR to less than 15 ml, need for dialysis, renal death, cardiovascular death, all put together, it has a beneficial effect. So it favors canagliflozin compared to the placebo. This was an eye-opening study with regard to the renal outcomes. So what did people do after this? So they thought that we can take up people with low GFR also for the treatment with the SGLT2 inhibitors, look for both renal protection and cardioprotection. And the similar studies, the Credence study, as time went on, showed that by about 3 months to 4 months, there was a fall in GFR, the blue line. But after about a year, the placebo arm showed a rapid fall in GFR, whereas canagliflozin showed that the GFR was getting stabilized. It did not fall that steeply as it happened with the placebo. So people started worrying about this initial fall in GFR with the gliflozins. And the explanation that was given was that as it was given for RAS blockade, initially by reducing the individual glomerular filtration, there will be a fall in GFR, but in the long run that proves to be renoprotective. So the acute elevations in serum creatinine or fall in eGFR, when it is induced for a therapeutic purpose, with either RAS inhibitor or with SGLT2 inhibitors, in the long run are associated with a better outcome. Whereas if we have a spontaneous acute kidney injury in a diabetic or in a person with CKD, due to other factors like cardiac failure, hepatorenal factors, sepsis, nephrotoxin, etc., this fall in GGFR and IKI will be deleterious. So there's a difference between an induced therapeutic fall in eGFR and a spontaneous disease-related fall in GFR. So that we have to understand. Finally, coming to the final part, based on these observations, these studies were extended to people with CKD. For example, the DAPA CKD and the EMPA kidney trials. The initial feature of these studies was that they included not only diabetics with kidney disease, but also kidney disease people without diabetes. So whether DAPA CKD, the aim was to see whether it will improve kidney and cardiovascular outcomes in patients with CKD. It was a randomized double-blind study, 386 sites in 21 countries, total number was 4,304. The decline in GFR to at least 50% was taken as the primary endpoint. People reaching ESKD and death from renal cause. Cardiovascular endpoints were hospitalization for heart failure, death from cardiovascular causes. GFR included was 25 to 75 ml. Even low GFR people were included in the study. 67.5% of the population included were diabetics, and the remaining were non-diabetics with CKD. And the albumin creatinine ratio was in the range of 200 to 500 milligrams per gram. So the population selected was stage 3 or 4 CKD with high levels of proteinuria, which means the highly vulnerable group for renal disease and cardiac disease progression were selected, and in that group, the effect of dapagliflozin was aimed to be studied. The outcomes. The placebo arm had 2,152. The dapagliflozin arm had 2,152. Comparable. When you look at the placebo effect, the composite outcome, both renal and cardiac, was 14.5, which came down to 9.2 with dapagliflozin, which change was statistically significant. You take kidney outcomes only, doubling of serum creatinine, renal death, etc. With placebo, it was 11.3, and with DAPA, it was 6.6, statistically significant. The cardiovascular outcomes were a little inferior compared to the renal outcomes. The difference was 6.4 to 4.6, and the p-value was not very significant. Death from any cause came down to a significant extent. Concluding, patients with chronic kidney disease, either with or without diabetes, the risk of any composite kidney or cardiovascular outcomes or death was significantly lower with dapagliflozin than with placebo. So now we have an anti-diabetic agent which is helpful to slow not only renal problems but also cardiac issues in these people with CKD. The other study, just for comparison, I have shown, but this is yet to be completed. The results will be out in June 22. Using empagliflozin, it also studied CKD, including type 2 DM and non-diabetic patients, excluded type 1 diabetics. Number studies were 5,000. EGFR 20, more than 20 to less than 45 were included, or those who had a higher GFR but with more proteinuria. And similarly, the endpoints were similar: doubling of serum creatinine, sustained decline in EGFR, reaching end stage or renal death, cardiovascular death, heart failure, hospitalization, and all-cause mortality. The results are awaited, but from the DAPA kidney, which was the result was released rather early because of the very promising outcomes with the DAPA CKD trial. We expect a similar improvement with EMPA kidney also, and that adds another armamentarium in our hands. Coming beyond diabetes, are there any general measures that will help to reduce or reverse the progression of CKD? We were talking so far about the glomerulus, proteinuria, and hypertension, but the extent of tubulointerstitial changes that happen in CKD are the ones that contribute to the final common declining pathway. The tubulointerstitial fibrosis, tubulointerstitial edema, the atrophy of the tubular cells, and the fibrosis that results from all that leads to the constriction of the kidney itself, contributes to contracted kidney as we see in later stages of kidney failure, and contributes to worsening of hypertension and a progressive fall in GFR. As it was alluded to, there may be a subcategory of CKD and even diabetics who do not have much proteinuria, but have a tendency to falling EGFR rather quickly. These are the candidates who have preferential tubulointerstitial disease and have a rapidly progressing tubulointerstitial fibrosis. So is there anything for reducing this tendency for fibrosis? There are quite a few substances that are being studied. For example, trials to ameliorate fibrosis are assessing TGF-beta inhibitors, connective tissue growth factor inhibitors, the BMP7 agonists, and endothelial antagonists. But we do not yet have very useful information about these things. One medicine that has proven to be useful as an antifibrotic agent today are the mineralocorticoid receptor antagonists, the eplerenone and the awaited finrenone are the ones who have got an antifibrotic effect, but more such drugs are in the pipeline. So with that, I will try to conclude and stress again that there are many areas in which there have been newer advances, but I took two areas in particular, namely what is happening in anemia management and what is happening in diabetic nephropathy with the use of SGLT inhibitors. We may have some more such substances in the management of CKD, and that will help us to hold on these patients for a longer period and slow down the rate at which kidney disease progresses. Thank you.
Thank you, sir.
Yes.
Dr. Ramasubramanian sir is here.
Yes.
Am I audible?
Yes, sir.
Yeah,
Audible, sir.
Yes.
Am I audible? Sir, Dinakar sir, good evening, sir. Sorry for joining late, first of all.
Yeah.
The original time was 8:45. See,
okay.
As usual, your talk was very clear and very elaborative, sir. You talked about the HIF and the SGLT2 inhibitors and the credence and the DAPA study and other important developments in the CKD management. Friends, see, CKD is an important non-communicable disease, and roughly 10 to 15% of the population in our country is supposed to suffer from CKD. And as you all know, the ultimate management of end-stage renal disease is transplant and the dialysis or maintenance hemodialysis. But it's time for us now to prevent the patients from reaching that ESRD. So as Sir told, there are a lot of drugs, the SGLT2 inhibitors. They are no longer considered as diabetic drugs, but they are considered as kidney drugs, which can slow down the progression of the kidney disease. Thank you very much, sir, for your elaborative and excellent talk, sir. And any questions? I think a lot of questions in the chat box. I think sir will be replying.
Okay.
Thank you for the opportunity.
Subramaniam, read
okay,
the chat box.
Milas, I will read. So, how far IV iron induce further renal damage in CKD patients?
That used to be a constant fear. As long as you monitor the serum iron levels, and as long as the ferritin levels do not go very high, iron as such need not cause further renal damage.
Okay. Next question. How accurate is HbA1c in CKD patients, as low HbA1c of less than 6.5 or more than 9 are markers of higher mortality?
No. The fallacies of HbA1c in disease is related to the severity of the anemia. But till date, that is the best indicator for long-term glucose management, even in a diabetic with kidney disease. So, for want of a better substance, which can be practically useful, we are still relying on HbA1c. It is a very good marker. Going below 6 in a person with kidney disease, already existing cardiovascular morbidities, will be risky. 7 is the level at which we try to stick on. But they also may need some relaxation in the elderly, people who have very advanced kidney failure and who may be prone for hypoglycemia, we aim at tight control of blood sugar, and those who have already pre-existing cardiovascular ailments will have to go slow. But maybe in that situation, we can keep the HbA1c around 7.5 to 8.
Thank you, sir. Next question is there a relationship between reduced magnesium level and erythropoietin non-responsive patients in CKD?
Reduced iron levels.
Reduced magnesium levels.
Magnesium
levels. I don't think it plays a direct role. Magnesium has something to do with the musculoskeletal symptoms. It can worsen the potassium disorders, and it can contribute to the illness of CKD.
Okay.
Magnesium deficiency as such doesn't contribute too much to anemia.
No. And there are a few questions about remagliflozin. Mohan sir is asking.
No, there are some studies which have come recently, but head-to-head comparisons are not available, and studies on cardiorenal protections are not available. But the overall consensus is that the gliflozins have the same effects as a class. So maybe we can use it, but as you know, one company has brought down the cost of dapagliflozin, 10 milligram to 17 rupees and 5 milligram to 14 rupees. So the price war has started, and the patients and the nephrologists will stand to gain.
Competition. So one last question, sir. Until what eGFR level SGLT2 inhibitors can continue?
As far as the trials go now, up to 30 ml GFR, the drug has been used. In the Credence study, they first stopped with a GFR of 45 ml. But as the patients were followed up, their GFR went down, and they did not withdraw the SGLT inhibitor, canagliflozin, till they reached a GFR of 30. So based on this, the recent studies, the DAPA and the EMPA kidney study, have recruited people from above 25 ml itself. So maybe, but based on that, we can project that we can use it up to a GFR of 25 ml per minute. The doubt comes in the mind of the physicians. At that level of GFR, the glucose filtration itself may be low. What does SGLT2 inhibitor going to do? That's why we look into the other mechanisms of SGLT2 action beyond diabetes control. There are many mechanisms that have been postulated. One important mechanism is the tubular-interstitial reaction that occurs to reabsorb glucose in the presence of SGLT2 activity. So all these do happen even at lower levels of GFR, And so SGLT2 inhibitor is able to offer this renal and cardio protection even at low GFR levels.
Okay, sir. So thank you. I'm sure there will be many more questions. Thank you for your time. That's a very excellent talk, sir. Thank you. Thank you, Chairperson, also.
Thank
So-
you.
Thank you. Thank you so much.
Thank you.
Yes. And
So next will be the final talk for tonight is by Dr. Chenniyappan on cardiology. He has already joined, and Dr. Ravi Edwin, Professor and HOD of Cardiology, TVMCH, is going to chair the session. So both of you, welcome, sir.
Good evening.
Good evening, sir.
Please, sir. Have you been?
Sir has joined already. Ravi, sir. Ravi, sir, are you there?
I phoned him. He told he has joined.
Ama. Let me look at it in a different way. I've just admitted him, so it should be there.
Sir Ravi sir, please unmute your mic, sir. We are sending a request. Sir Ravi sir needs to be unmute his mic.
Yeah. Hello?
Okay. Yeah. Welcome.
Yeah, please go ahead.
Yes, sir.
Yeah.
Ravi, introduce the topic.
Hello?
Yes, sir. We can hear.
Hello, good evening, everyone.
Thank you.
I think, thank you so much for the invite, for the wonderful topic.
சரி ஆல்ரெடி சொல்றேன் ஒரு மஷ்ரூம் ஃப்ரைட் ரைஸ் ரெண்டு ஏதாச்சும் ரைஸ் சொல்லு ஒரு கோதுமை
Hello.
Everybody.
ஆமா, somebody is fried rice order பண்றாங்க நமக்கு.
Unmute them.
Okay, I unmuted everyone. Yes, sir. Ravi Edwin, sir, go ahead, sir.
Yeah, Dr. Chenniyappan needs no introduction. He is a teacher of teachers, professor of professors, so deeply interested in taking classes for all cardiologists, physicians, for national and international people. And he is presently a consultant cardiologist in Ramakrishna Narsingam, Trichy, and he is emeritus professor, Tamil Nadu, Dr. MGR Medical University, Chennai. He is a director of medical education, Apollo Specialty Hospital, Trichy. He is an honorary national professor of IMA, CGP, and he is acclaimed cardiologist among trainees, both ECG and Echo Club, and many national awardees and fellowships, and around 40 publications he has made in his name. He is orators in conferences. Now we are going to hear a wonderful topic, STEMI dilemmas. Sir,
I'll stop my. Okay, so I'll done that, sir.
New to the Tirunelveli APA. He has conducted many workshops and many CME for our APA Tirunelveli. Welcome, sir.
Yes. Yes, sir. Welcome, sir. Chenniyappan, sir.
Yes.
Yes, sir. Well done. Okay, good.
Good evening, sir.
Thank you.
Good evening, Dr. Ravi Edwin, Dr. Mohan, Dr. Subramaniam. I thank you for this wonderful opportunity. I apologize for joining late because of some technical issues, and My topic today is going to be a little bit different topic, not based on, so you will not see any Kaplan-Meier curves or forest plots and like that. So you've been seeing since evening all this. So what I'm going to show you some the very attractive curves which you can see in the ECG. So although we day in and day out, we treat ST elevation myocardial infarctions, but there are a lot of diagnostic dilemmas which are existing in this STEMI. And the dilemma means a situation in which a difficult choice has to be made between two different things you can do. That is how to treat a STEMI, whether we want to give a thrombolysis or not, and so on. So I like to speak without my video, because having done the many lectures, seeing audience, it is very, very embarrassing to see my face and talk. So usually I switch off my video while I'm talking. So please pardon me for that. So the next is the dilemma. Having seen that dilemma, we go to this, and we all know that we are the world #1 in coronary heart disease. And are we world #1 in the treatment of acute coronary syndrome? This is a Kerala registry, which is published in European Heart Journal in 2013, said mortality in STEMI till it is around 8 to 9%, which is 3 times higher in Western world. And what is very distressing to know is 41% only received thrombolytic therapy in ST elevation myocardial infarction, only, and 19% received thrombolytic therapy wrongly. That means 41 plus 19, almost 60% of the patients are not getting the right treatment in acute coronary syndrome. This is because of incomplete understanding of the ECG and diagnostic dilemma on how to manage an acute coronary syndrome. So this is my plan of talk. So we'll try to give you some dilemma of definitions. Then we look at pathophysiology of acute coronary syndrome. Then how to diagnose STEMI first from the ECG. The dilemma #1 in STEMI is not seeing what is there. What are the situations in which you will miss STEMI? Dilemma 2 is seeing what is not there. You are misdiagnosing STEMI. And having diagnosed STEMI, am I correctly managing STEMI is the third dilemma. Then we give you some takeaways. So the dilemma of definition is the myocardial injury is different from myocardial infarction. So the first dilemma, whenever a troponin is positive, it is called myocardial injury. There is some injury to myocardium, not necessarily due to coronary heart disease. So myocardial injury in the absence of coronary heart disease can happen in many situations, including anemia, a rapid ventricular arrhythmia, heart failure, kidney disease, and hypotension, shock, and low oxygen. So all these things, many conditions can produce myocardial injury, which will elevate cardiac troponin. But in the presence of myocardial injury, only when you have a clinical ECG and echo evidence of acute myocardial ischemia or acute myocardial ischemic insult, then only you call them as myocardial infarction. So in the presence of troponin positivity, if you have a classical chest pain, or you have acute ECG changes of ST segment elevation or depression, or a pathological Q wave, or your echo shows new wall motion abnormality, then only it becomes infarction. So that is the difference between injury and infarction. So not all troponin positive patients are not going to be having myocardial infarction. So myocardial injury of troponin positivity plus clinical ECG or echo evidence of acute ischemic insult or acute ischemic insult to the myocardium, then only you can call that as myocardial infarction. So this is approach to any patient with chest pain. Your ECG shows evidence of acute coronary syndrome. Then you must see whether it is ST elevation ACS or non-ST elevation ACS. Non-ST elevation ACS may be in the form of ST segment depression or a symmetrical T wave inversion. So in the persistent ST segment elevation, the STEMI, the reperfusion is the mode of treatment by either pharmacological means or by mechanical means. Whereas in non-ST elevation situation, if the troponin is positive, they are called non-ST elevation myocardial infarction. If the troponin is negative, they are called acute unstable angina. So the difference in acute non-ST elevation ACS, the difference between STEMI, non-STEMI and unstable angina is decided not by the electrocardiogram, but by the presence of troponin positivity. So in non-ST elevation ACS, troponin positivity is non-ST elevation MI, troponin negative is unstable angina. Whereas in ST elevation, don't wait for troponin to thrombolize a patient, because troponin takes 2.5 hours to become positive. The patient is coming to you with 1 hour of chest pain. And if a troponin negative, it doesn't mean the patient does not have acute arterial occlusion. So the main purpose of troponin is primarily in non-ST elevation ACS to characteristics into high risk non-ST elevation MI or a low risk acute unstable angina. Then we look at the pathophysiology of acute coronary syndrome, which can be non-ST elevation ACS or ST elevation ACS. It all depends upon how the plaque, the atheromat of plaque is going to behave and what is the type of thrombus it is going to be formed. In non-ST elevation ACS, most often it is a plaque erosion, which exposes some component of the plaque to the circulation. And here in non-ST elevation ACS, only platelets are getting activated. Because the platelets are getting activated, the thrombus which is formed on this plaque erosion is likely to be rich in platelets, and it is a white thrombus. The amount of formation of thrombus itself is going to be not very huge thrombus, particularly occlude a coronary artery and not totally occluding a coronary artery. So because of this critical occlusion due to white thrombus, the injury that happens in the myocardial level is going to be subendocardial injury, which is most often prone for this earliest evidence of lack of blood supply. So the subendocardial region gets affected. So subendocardial injury produces ST segment depression when the patient comes with acute chest pain. So because the thrombus is not rich in fibrin and the coagulation system is not getting activated and the thrombus is not totally occluding the artery, the treatment for a patient who comes with acute chest pain and ST segment depression is either interventional therapy or a pharmacological therapy like heparin, dual antiplatelets, and hydrostatin, and no thrombolysis in these patients who are coming with ST segment depression. Whereas in ST elevation ACS, what happens is a plaque rupture. What happens when the plaque ruptures is not only the superficial portion of the plaque, but also the deep portion of the plaque, which is the lipids, are getting exposed to the circulation. Because of that, it is not only the platelets gets activated, it is a coagulation system which gets activated. Because of the coagulation system activation, the thrombus which is going to be formed is a huge thrombus. Along with the platelet, there is also fibrin in thrombus. So here, when the plaque ruptures, the occlusion becomes total and the thrombus becomes red because it is rich in fibrin. So because this thrombus is rich in fibrin and you have got total occlusion, you have a predominantly subepicardial injury or a pan injury of the myocardium, which is predominantly subepicardial, which produces ST segment elevation. So because the ST segment elevation is because a huge thrombus, which is completely occluding the artery, producing very significant injury to the myocardium, which results in ST elevation. Here, because the thrombus is totally occluding, and also the thrombus is rich in fibrin, the treatment is likely to be a thrombolytic therapy, which can lyse this thrombus, or a primary PCI, where you can go in and open the artery fully. So this is the concept of the ST elevation ACS. Although the patient is coming with a similar chest pain, it is the ECG which decides whether you have to give a thrombolytic therapy or no thrombolytic therapy. With the patient, the ST segment depression means critical occlusion due to white thrombus, thrombolysis is not indicated. Whereas the patient comes with ST segment elevation, it means total occlusion with a red thrombus, thrombolysis is indicated. So when you look back at the Kerala registry, only 41% patient who needed thrombolysis were thrombolized, and 19% of patients who had ST segment depression is wrongly thrombolized. So that's why the ECG knowledge is crucial to decide the important, immediate, and correct treatment of acute coronary syndrome. So when the patient comes with acute chest pain and has got a huge ST segment elevation like this, you immediately know three things. One is it is acute occlusion, second is total occlusion, and third is thrombus rich in fibrin. So you have to use a fibrinolytic therapy here and PCI or fibrinolytic therapy. Whereas the patient comes with acute ST segment depression, three things here: acute occlusion, critical occlusion, white thrombus, and no thrombolysis. Depending upon the risk of the individual, the patient goes for interventional therapy or conservative management. So now, how are we going to diagnose ST elevation ACS? To diagnose ST elevation acute coronary syndrome, you have to look at the ECG, and the two consecutive leads should show ST segment elevation. The two consecutive leads supplied by the same coronary artery. The baseline is PR segment. The ST elevation is measured from the J point where the QRS meets ST segment. The amount of J point elevation from the PR segment decides the definition of STEMI. In V2 and V3, if the patient is a male and less than 40 years, ST elevation has to be equal or more than 2.5 millimeters. In V1 and V2, if the patient is a male and more than equal or more than 40 years, the ST elevation has to be equal or more than 2 millimeters. In females, all ages, the ST elevation should be equal or more than 1.5 millimeters. Whereas except these leads, in all the other 10 leads, ST elevation has to be more than 1 millimeter, irrespective of the age, irrespective of the sex. The ST elevation should be equal or more than 1 millimeter in two consecutive leads supplied by the same coronary artery. So there are certain ST elevation infarction equivalents such as left bund branch block and reciprocal ST segment elevation V1 to V3. We are going to see some ECGs on this segment also. But the problem is, if the patient is coming with a classical things like this, where there's a classical ST elevation, it is very easy to decide acute occlusion, total thrombus, total occlusion, red thrombus, and thrombolysis in this patient. But unfortunately, diseases don't read textbooks. They do not come and exactly present with the classical criteria I have mentioned. So that's why the dilemma comes. The first dilemma is not seeing what is there. In which situation you are going to miss an ST elevation ACS or its equivalents, where an immediate angiogram may be necessary or immediate thrombolysis may be necessary. So the first dilemma is, here I have in 3 leads, I have ST elevation, but 9 leads are showing ST segment depression and T wave inversion. So naturally, the dilemma comes, when 9 leads are showing ST segment depression, should I call this as a ST elevation ACS or a non-ST elevation ACS? The important rule is, irrespective of number of leads showing ST segment depression, if 2 consecutive leads show ST segment elevation more than 1 millimeter in limb leads, more than 2.5 or 1.5 millimeter in chest leads, it is STEMI, irrespective of the number of leads showing ST segment depression. So 2 consecutive leads, ST elevation more than the criteria I have mentioned, makes it STEMI rather than non-STEMI. So the STEMI and non-STEMI are not decided by number of leads having more number of leads having ST segment depression or elevation. It is decided only by 2 consecutive leads having more than 1 millimeter of ST segment elevation. Then the earliest evidence, ECG evidence of ST elevation MI is the ironing out of this gentle concavity. Usually the patient manifests in V2, V3, and V4 for that any lead. This is a normal ST segment which smoothly merges with the T wave with a gentle concavity upwards. Whereas here we can see the earliest sign of ST elevation MI is ironing out of this concavity, which we call as a slope ST elevation or a shark T wave. So this is the earliest elevation. Most often it is missed. For example, look at this electrocardiogram here, the V1 and V2 showing ST segment depression. So this is the one which catches your eye and you think it is non-ST elevation ACS and not thrombolizing the patient. If you see the lateral leads V5 and V6, compare the ST segment in V4 and V5 and V6, you can beautifully see that the absence of this concavity and the ST has become sloped ST elevation, not only in the lateral leads, but also in the inferior leads. You can see that slope elevation. So this is actually ST elevation MI involving the inferior wall, lateral wall, as well as the posterior wall, which is presenting as anterior ST segment depression. So if you are not thrombolizing this patient, you will lose the lateral wall, inferior wall, as well as the posterior wall. So this is the one which most often missed in ST elevation myocardial infarction. So this is the earliest change of ST elevation myocardial infarction. So here the patient may come to you with half an hour or 45 minutes of chest pain. So this is a change you have to concentrate, not to miss STEMI. So this is a slope elevation of ST segment. Then you can see, once again, you can see V2, V3, and for tall T waves, some amount of loss of concavity here. So you don't do anything here. The next ECG, you can see a significant Q wave formation. So entire septum has gone. So missing this earliest sign may make the patient to go for a classical, completely dead myocardial involvement. Then, of course, that whenever you have an inferior wall myocardial infarction, if ST elevation is more in L3 when compared to L2, it tells you right coronary artery is involved. Then the second step is to see whether the right coronary is proximally occluded or distally occluded. It all depends upon right ventricular myocardial infarction. So in the presence of RC occlusion, if the right ventricular myocardial infarction is there, it is likely to be a proximal occlusion. For that, you always take the lateral leads. Or lateral leads, you always take the right serral leads. If the right serral leads show V4 or showing ST elevation, you think it is right ventricular infarction. So it's a proximal right coronary disease. But if you don't have the right serral leads, look at the discordant ST segment depression between the V2 and V1. So here, the V1 not only behaves as the right serral lead, it also behaves as a posterior reciprocal of the posterior lead, which is an anterior lead. So posterior infarction tend to produce ST segment depression here, and right ventricular infarction tend to produce ST elevation here. So what you have is normalization of the ST segment here. So this is a disproportionate ST segment depression, V1, V2. Discordant ST segment depression is a sign of RV infarct. So in 12-lead ECG, even though you don't have the right serral leads, you can diagnose right ventricular infarction. So you will not miss a right ventricular infarction, even though right serral leads are not there, if you are carefully looking at this discordant ST segment depression between V1 and V2. Sometimes when you see this electrocardiogram, what takes your attention is V2, V3, and V4, significant ST segment depression. You immediately jump to non-ST elevation ACS and start treating this patient. But any ST depression in anterior lead, always look at inferior leads. There is a small ST elevation V2 with L2, L3 AVF. And what is happening here is inferior wall infarction with a significant posterior ST segment elevation, which results in anterior ST segment depression. So any anterior ST segment depression, don't forget to look at inferior leads. So even a small elevation, 1 millimeter elevation, tells you it is a reciprocal of posterior rather than acute critical occlusion of left antedescending artery. So many times what we see is reciprocal changes are coming early and also coming very prominently than the real ST elevation happening somewhere else. One more example of that is here. You can see that once again, I told you the loss of concavity here, and here looks like there is a ST segment depression L1 and AVL. You think it may be acute critical occlusion of high lateral wall, but most important thing is you have to, whenever you have ST segment depression L1 and AVL, keep concentrating on inferior wall infarction, and this may be the reciprocal change. Most often AVL depression will appear very prominently and very early before real ST segment elevation happens. When this patient undergoes a coronary angiogram, it is classically the right coronary artery totally occluded, which tells you this ECG changes primarily because of evolving inferior wall infarction rather than a circumflex disease. The presence of left bundle branch block is always a problem here. Whenever left bundle branch block is there,
disconnect audio.
Previous guidelines have told us that acute left bundle branch block may be an indication to thrombolyze the patient. But the patient comes with the first ECG, you are not sure whether this is an old left bundle branch block or acute left bund branch block when you have only one ECG. For that, we look at what is known as a Scarbosa criteria. So in a classical left bund branch block, discordant is the rule, which means when the QRS is upright, ST segment and T wave will be in the opposite direction because of the depolarization delay, repolarization and depolarization happening from endocardium to epicardium make this discordant. QRS is up, ST and T wave is down. When the QRS is down, ST and T waves are up. So discordance is the rule in an uncomplicated left bund branch block. Whereas the Scarbosa criteria, there is concordance. In V5, V6, where you expect ST segment depression and also the T wave inversion, ST segment is upright along with the QRS. The T wave is upright with the QRS. So if you have ST segment elevation here in V5, V6, it is a concordance. This gives you 5 points. Whereas in V2, in previous CC you have seen, there is a ST segment elevation when the QRS is down. In V1, V2, when the QRS is down, ST is also down, and this will tell you that the patient has got one more concordance because here you expect ST elevation. Here, the QRS is down and the ST is down. So it has got 3 points. Whereas in V2, if there is excessive discordance in uncomplicated left bund branch block, the ST segment elevation can be up to 5 millimeters here. If there is excessive ST elevation more than 5 millimeter, this is excessive discordance, which has got 3 points. So totally you have 10 points. So any criteria of this Scarbosa more than 3 points, we have more than 3 have a very good specificity and a low sensitivity to diagnose and definitely diagnose myocardial infarction in the presence of bundle branch block. Look at the ECG here, V5, V6, especially in V6, you can see the ST segment is in direction with the QRS and the T wave is also in direction with the QRS. I will be more confident in thrombolizing this patient who has got this Scarbosa criteria rather than thrombolizing this patient who has got a classical discordance. So in this way, the subtle sign of concordance will help you to diagnose ST elevation MI in left bund branch block so that you can thrombolize and not to miss. One part is if you are not concentrating on this and you may thinking it is a classical left bund branch block, you are not thrombolizing it. Whereas here, if the patient does not have a STEMI and you are just thrombolizing a patient with a pure left bund branch block, it is also a problem to the patient. So that's why the application of Scarbosa criteria will help you to diagnose a STEMI in the presence of a left bund branch block. So having finished where you can miss STEMI, I am now coming to STEMI equivalence, which has got the same importance like STEMI, but there is no ST elevation. That means all these examples I am going to show is very critical occlusion of an left antedescending artery or left main artery, where all these patients should go for coronary angiogram at the earliest. There is no question of thrombolysis. There is no question of heparin. There is no question of antiplatelets. First is called De Winter's sign. The De Winter's sign classically appears in V2 and V3 and V4, which has got a horizontal, small horizontal depression and very tall hyperacute T wave here. So T wave is more than QRS here. So this type of downs the ST segment depression and a very tall T wave, this combination is called De Winter's sign. And the De Winter's sign you can easily recognize by this type of ST segment depression and a very tall T wave. And De Winter's sign is considered to be STEMI equivalent. So here is that it's a critical occlusion, very critical occlusion of LAD or a total occlusion of LAD. This patient should go for earliest angiography. Then, of course, many of you would have seen this type of electrocardiograms many times. It is anterior ST segment depression with the ST elevation in lead AVR, which is a sign of critical left main occlusion. Once again, this is a STEMI equivalent. This patient should go for immediate early coronary angiography. So if the ST elevation is there with 1 or 2 leads showing ST segment depression in lateral leads and ST elevation is there in AVR, it could be a pure left main coronary artery occlusion. when there are ST segment depression is there in more than 5 leads plus AVR ST elevation, tells you it is a critical left main disease plus triple vessel disease. Once again, indication for early coronary angiogram. Then we come to this patient. The patient had chest pain yesterday. Today, he does not have chest pain, but he has a very deep symmetrical T wave inversion, V2 and V3, V4. This patient will be completely stable. He will not have chest pain. And at this patient, he come to you just as an OP patient because he had chest pain yesterday. Your attitude or your approach may be that, okay, there is some T wave inversion, give him some vasodilators, antiplatelets, and statin. So this is called the Valence sign, the deep symmetrical T wave inversion without the loss of R wave is called the Valence sign. Just like D Winter's sign, this once again tells you, although the patient is hemodynamically stable, does not have chest pain. When compared to all the other ECGs, the Valence sign appears in the absence of chest pain. That's why it is most often missed and not treated properly. So once again, this patient will need an early coronary angiogram because of critical proximal LAD needs an early coronary angiogram. So having seen the dilemma of what, got to the dilemma 2, in which are the situation which we are going to diagnose wrongly as STEMI and treat it wrongly with a thrombolytic therapy. So the most important condition is called early repolarization syndrome. V2 and V3, you can see the ST elevation, but the important difference is this ST elevation is with a concavity upwards, and there is a notch between the ST segment and the QRS. So this notch and the concavity of the ST segment will tell you it cannot be STEMI and it is likely to be early repolarization. These patients also come with some sort of bradycardia and sort of retrosternal chest pain because of the associated acid peptic disease and the vagal stimulation. So you'll have all the tendency and all the temptation to give a thrombolytic therapy here, but you have to carefully look at the ST segment and this notch, which tells you it's an early repolarization syndrome. In acute pericarditis also, you can have diffuse ST segment elevation. Once again, we can wrongly diagnose it as STEMI, but the important differences are here, there is ST elevation is not confining to a particular coronary artery, and the only lead which will show ST segment depression is lead AVR, and this ST segment elevation will be with concavity upwards, and there will be no evolutionary changes. In second day or third day, in ST elevation MI, you will have a coving ST segment, symmetrical T wave inversion. As pericarditis may not have the classical evolutionary changes of STEMI. In addition to that, you will have a PR segment depression in L2, L3 AVF, the PR segment depression, ST elevation with concavity upwards, diffuse ST segment elevation, and also there are no evolutionary changes and clinical evidence of pricking chest pain associated with the respiration and the presence of pericardial drop. The clinical electrocardiographic correlation will tell you this ST elevation is due to pericarditis and not due to STEMI. So PR segment depression, AVR ST segment depression, and a diffuse ST elevation with concavity upwards. This patient comes with acute left arm pain for 3 hours. When you have ST segment depression, V2, V3, and ST elevation, V2 and V3 and V4, you tend to thrombolize this patient. But unless you compare the previous ECG, this is a ECG taken 1 year back, has got the same ST changes. You can see that here, the same ST changes in 2012, and this is 2011, same patient, same changes. So persistent ECG changes can happen, ST elevation can happen in especially left ventricular aneurysm. So don't jump to thrombolize a patient just looking at the single ECG taken on that day. Always compare with the previous ECG to know whether that ST elevation is fresh or existing for many number of years, where the diagnosis is likely to be left ventricular aneurysm. Hyperkalemia will produce a tall T wave and mimic an acute coronary syndrome or ST elevation myocardial infarction. Here, the important point, electrocardiographic point is after the QRS, you don't have the ST segment at all. After the QRS, you will straight away have the T wave, and it's no classical ST segment elevation like this. As you can see it here, it is the entire T wave will be sitting on the QRS, a very sharp T wave, very broad T wave will make you diagnose a diagnosis of hyperkalemia rather than ST elevation myocardial infarction. Pulmonary embolism, because of the acute RV injury, can have ST elevation V2, V3, and V4. The patient is presenting with acute dyspnea rather than acute chest pain, must alert you. And also after DC shock, you can have ST segment elevation. Some of the patients with the hypertrophic cardiomyopathy will present with ST segment elevation changes rather than tall R waves in lateral leads and V1 and V2. So this is because of significant myocardial fibrosis, which produces some amount of injury to the myocardium and presenting with the repolarization changes rather than depolarization changes. The important point about this type of ECG changes in hypertrophic cardiomyopathy is, even though these patients do not have obstruction, these patients are at the risk of sudden death because of this fibrosis presenting as ST segment elevation. So the presence of the clinical correlation of hypertrophic cardiomyopathy and the presence of type of chest pain, these patients will recurrently admitted in the hospital, diagnosed as SEMI. If you compare the previous ECGs, these ECGs will show exactly the same changes. So this type of repolarization changes will have a bad prognosis. Then we come to the Brugada syndrome, where you can have the slope ST elevation, the downsloping ST elevation in V1 and V2 alone. So this is very important to differentiate between anteroseptal myocardial infarction, where your ST elevation is going to be progressive from V1 to V4. Here, the Brugada syndrome, there is a mimicking a right bund branch block, and slope elevation, downsloping elevation, ST elevation is a classical Brugada syndrome. So this, you should not mistake it for STEMI and treat it as SEMI. So this patient comes with chest pain and epigastric pain for the last 3 to 4 hours. He has vomiting, highly restless, and rolling because of the abdominal pain and chest pain, and ECG is showing ST segment elevation. So you'll have all the temptation to immediately thrombolize this patient. But important thing is correlation and clinical examination. In addition to all this, the patient has got a little bit of guarding, abdominal tenderness, was persistently vomiting, he is an alcoholic. So this patient has ECG of acute pancreatitis. So once the acute pancreatitis is managed, you can see the patient has come to a regular normal electrocardiogram. So pancreatitis can produce a lot of ECG changes because of the proteolytic enzymes released from the pancreas can produce some amount of injury to the myocardium, as well as the electrolyte changes which is happening in acute due to acute pancreatitis. Imagine the consequences. You think this is a ST elevation MI and give a thrombolytic therapy in a patient and also the antiplatelets and statin in a patient who has got acute pancreatitis. You just imagine the consequences. This young man comes with cardiogenic shock and he has got diffuse ST elevation. So you can see the diffuse ST elevation with cardiogenic shock, and you think it is a very severe myocardial injury and all of the arteries are totally blocked. So please remember that once again, the history is important, and within 36 hours, without thrombolysis or PCI, the patient's ECG became absolutely normal. You cannot imagine this ECG becoming absolutely normal after 36 hours without the thrombolysis or PCI. The cause of this ST elevation is to poisoning due to aluminum phosphide. Aluminum phosphide is a very severe poison which is used as an insecticide for coconut trees, and this completely shuts off the cytochrome system. So the entire myocardium does not receive oxygen. Because of that, anything which stops oxygen to the myocardium will undergo injury and will produce ST segment elevation. So this patient with the history, you can see when he's treated for the poisoning, the ECG becomes normal without thrombolysis. So this is aluminum phosphide poisoning. And of course, athlete individuals with a bradycardia, they can also have some ST elevation and sometimes normal ST elevation. So this is an absolutely normal patient. No chest pain, nothing. ECG is normal. We even did coronary angiogram and stress perfusion studies. Everything is normal. So this is an ST elevation in a normal person, which can also happen as a normal variant. This type of changes have been described in Black Americans, or so this is Afro-Americans, and this is also can happen normally. Then, of course, the one important thing you have to remember between the ST elevation, between non-coronary cause and the coronary cause is the ST segment concavity upwards is most often non-coronary, whereas ST convexity upwards is most often coronary. So whenever your ST is smiling, I think it's benign. Whenever your ST is sad, it is dangerous. So this type of coving ST is dangerous, whereas this smiling ST is most often benign or early repolarization syndromes. Contrary to belief, in emergency room, most common causes of ST elevation is not ST elevation ACS. It is many times other causes like left bund branch block, left ventricular hypertrophy, early repolarization, and ventricular aneurysm. Then the last part is, am I correctly managing ST elevation ACS? Two forms of treatment for ST elevation ACS is mechanically opening the artery to the primary PCI here and also the thrombolysis. But this is the right type of treatment only when the patient has got acute total occlusion due to acute red thrombus formation, which means you can have STEMI without the thrombus. Look at the ECG here. The patient has got irregular QRS in atrial fibrillation, significant ST elevation L2, L3, AVF, and there is a reciprocal depression here. He also has a right bund branch block. So you have all the tendencies, you have all the temptations to give a thrombolytic therapy immediately. He already got one episode of syncope. He has got chest pain. He's a smoker. Blood pressure is 100/70. And after 10 minutes, his ECG has become absolutely normal. The ECG is normal, no ST elevation, no atrial fibrillation, no right bund branch block within 10 minutes of this electrocardiogram. What the intervention done? It is not primary PCI. It is not thrombolytic therapy. It is a sublingual nitrate. It is a Prince metal angina. So the Prince metal angina will come with ST segment elevation. Your sublingual nitrate or a calcium channel blocker immediately will relieve the chest pain and make the ECG normal. So that's why the indication to give a thrombolytic therapy is a nitrate resistant chest pain. So when the ST elevation is not coming down with the nitrates, then only it becomes a thrombus. So here we don't thrombolize the patient. This patient has got ST segment elevation, lateral leads, but this is a 50-year-old female and lost her husband recently. Any patient who has undergone recent acute mental stress will come with ST elevation, MI-like situation, or classically they have ST segment elevation in anterior leads most often or inferior leads. So here it is called Toku-Toshibu syndrome or acute ballooning sigma, apical ballooning syndrome. And here the injury of this ST segment elevation is because of the gross mental stress produced catecholamine storm. This catecholamine storm is actually damaging the apex more often than the base. So because of that, the significant apical injury produces ST segment elevation in lateral leads, and the base will be contracting vigorously because it is not affected, because we have lot of catecholamine receptors over the apex rather than the base. So this will typically produce a typical apical ballooning in echocardiography. So when you suspect an apical ballooning syndrome or Toku-Toshibu cardiomyopathy, don't thrombolize the patient. Immediately do a coronary angiogram, and the coronary angiogram will be normal, will establish the diagnosis of Toku-Toshibu syndrome. Here, the patient may not receive a thrombolytic therapy or heparin. Alpha and beta blockers are the definitive drugs which are indicated, along with the stabilization of hemodynamic status. So this is a classical apical ballooning syndrome. As you can see, the apical ballooning of this ST elevation is due to this apical ballooning. A predominant injury here. Here also there is injury, ST elevation. But this injury is due to the catecholamine-induced injury rather than thrombus-induced injury. There is no question of thrombolysis here. And of course, when the patient comes with acute chest pain, you have an ST segment elevation here, a severe back pain in this patient. And the differentiation between acute chest pain and back pain of the dissection versus ST elevation MI is the pain is maximal at onset in STEMI, in dissection, and it is gradual onset in STEMI. The pain character is tearing in dissection, predominant back pain in dissection, pain radiating into the legs is dissection, asymmetrical pulses is dissection, and presence of AR is dissection. So any patient with acute chest pain, especially the back pain, don't forget to rule out a dissection. Because of the coronary dissection, these patients also will come with ST segment elevation. Thrombolysis is contraindicated in those patients. Although this patient comes with a classical, one of the oldest ECG you have in 2004, it's a classical ST elevation, but the most important clinical correlation has told us this is an acute dissection, and a subsequent management of dissection is done rather than thrombolysis. Many times you have a dilemma when you have ST segment depression V1 to V3, whether it is a reciprocal or posterior ST segment elevation, where you have to thrombolyze this patient. Whereas if it's due to critical occlusion of LAD, you need not thrombolyze this patient. So very difficult decision here. If it is reciprocal, you have to thrombolyze. If it is true of anterior descending, you have to not thrombolyze this patient. So in this situation, one or two things will tell you that whether it is LAD critical occlusion or it's a posterior reciprocal ST segment depression. Usually the reciprocal depression of the posterior STEMI may not extend beyond V3. You can see V4 is normal here. It is confined to V1 to V3. Most often it is reciprocal. So this is one point. The most important point to decide whether I should thrombolyze this patient or not will be immediate echocardiography. So if it is a posterior ST elevation and reciprocal depression anterior leads, your posterior wall will show that the patient will have posterior wall hypokinesia, akinesia. Whereas if the anterior septum is going to show hypokinesia, then you know it's a true disease of LAD. You will not do a thrombolysis. So this is the dilemma, can be easily recognized or cleared by immediate echocardiography. So if the patient is coming with this type of ST segment depression V1 to V3, if your anterior wall or septum is akinetic or hypokinetic, you do not thrombolyze this patient, because this ECG changes because of critical occlusion of LAD. In contrast, if this ECG change is going to come with posterior wall akinesis or hypokinesis, that means you know this ST segment depression is reciprocal of the posterior ST elevation. So you have to thrombolyze this patient. So this is one situation where the echo may decide the decision regarding thrombolysis. In all the other situations, we depend upon the electrocardiogram. Then, of course, this lady comes with acute ST elevation in almost all leads, not confining to a particular coronary artery. She had fever and her heart rate is fast, a little bit of lower side of blood pressure, 40 years old, and burning chest pain. So this is due to myocarditis. Acute myocarditis, once again, the inflammation is producing injury to the myocardium. Epicardial injury to the myocardium can just present as ST segment elevation, and you should not mistake it as a STEMI and treat it with a thrombolytic therapy. Once again, the clinical correlation of young lady presenting with fever, tachycardia, may have some third heart sound, and also the fever and signs of myocarditis. A patient with a trauma here, we had ST elevation L1 and AVL with a reciprocal depression, classically mimicking high lateral myocardial infarction. The trauma itself can produce myocardial contusion, which is once again a reason for a myocardial injury. And you know, this patient should not be thrombolyzed. Once again, clinical correlation, clinical examination with the ECG. You imagine the consequences, a patient with a myocardial contusion being thrombolyzed with a streptokinase or tenecteplase. So once again, myocardial injury here is caused by trauma and not by thrombus. So give you some takeaways from this lecture of 3 parts, how not to miss a STEMI. So don't miss a STEMI, look for the subtle changes, a slope elevation, when you have a subtle elevation inferior leads and so on. And don't misdiagnose ST segment elevation. There is a lot of conditions which will mimic ST elevation ACS, like pericarditis, early repolarization syndrome, acute pancreatitis, hypertrophic cardiomyopathy. So even normal patients can have ST segment elevation. So don't misdiagnose ST elevation ACS. When you have ST elevation ACS, don't wrongly treat all ST elevation ACS with thrombolytic therapy. The thrombolytic therapy is going to be useful only when the ST elevation ACS or ST elevation myocardial infarction is due to acutely formed thrombus, Prince metal angina, acute ballooning syndrome, myocarditis. Everything will produce injury in ST elevation, but this ST elevation is not due to thrombus. So this is, you should not wrongly treat ST elevation ACS. So don't jump to thrombolysis in all patients with ST elevation. Not all ST elevations are STEMI. Not all ST elevation myocardial infarction ECGs need thrombolysis or PCI. Only those with acutely formed thrombus will need that. So because I told you we have so much of difficulty here, you can just ST elevation. I have mentioned so many conditions which can be STEMI, which can be STEMI mimic or no STEMI at all, but ST elevation. You have a classical ST elevation and chest pain, but you are not going to thrombolyze this patient. That's why the same ECG change will be having multiple conditions which can produce the same ECG change. That's why the ECG is difficult. Whereas in CT scan, you see a hemorrhage or infarct, it will be the same for your life. Only hemorrhage can produce that change, only infarct can produce a change. Whereas ST elevation here can produce multiple same ECG changes, can produce multiple conditions. Multiple conditions can produce the same ECG changes. That's why the ECG is difficult. The ECG is interesting because it is difficult. If you master something easy, it is not fun. But you master something which is difficult, it is going to be fun. So that's why ECG is interesting because it is difficult. Thank you for your patient listening.
Thank you, Dr. Cheniman, sir. That is very fabulous. So, Dr. Ravi Edwin, sir.
Hello.
Sir, yes.
Hello.
Okay, sir. Now it's okay. Good.
Hello.
Yes, sir. We can hear, but slightly.
Subramanian.
Kekudhu, sir.
Yeah. Thank you for your master.
கொஞ்சம் network issue இருக்கு சார், கிளியரா இல்ல.
Regarding the elements, yeah, be very much useful to all the physicians and cardiologists who just heard your masterly beautiful lecture, sir. Wonderful lecture. Thank you so much, sir. If there are any questions, kindly pass on.
So there is only one question posted. So one is, if an LBB does not meet Scarboso criteria, should we thrombolyze?
So it is a very important question that if the LBB is not meeting Scarboso criteria, then you have the clinical information is very, very important. Classical chest pain, you think that ischemic chest pain is very classical and the patient is sweating, retrosternal pain, you know, definitely it is ischemic pain. Then of course you can thrombolyze. And I will always advise in this type of difficult scenarios, look at the bedside echocardiography. So if it is available, immediately do a bedside echocardiography. There are a lot of differences between a classical left bund branch block where you will have only the jerky septum. The septum will be moving, but it will be abnormally moving. Whereas in STEMI, you will have absolutely akinetic or hypokinetic interventricular septum. So these are the two two answers for your question. So go with the clinical correlation, and if echo is available, immediately do an echo. Look at the septum. If it is a STEMI, you will have akinetic or hypokinetic septum and anterwall. If it is a pure left bund branch block, you will have a jerky septum, and septum and anterwall will be still moving, but it will be moving abnormally. So this is how we have to decide about thrombolysis. But if a facility is available in this type of doubtful STEMIs, it is better to do an immediate coronary angiogram and done with it, rather than deciding thrombolysis or not. So if the facilities are available, when you have a doubtful ST segment STEMI, it is better to do a coronary angiogram and decide according to coronary angiogram.
Yes, sir. Thank you, sir. That is the take-home message. So with this current age, sir, that's really wonderful. So we don't have any questions apart from this. Anybody want to ask question directly? You can unmute yourself and ask. It's 9:45. So I'm really thankful to both Dr. Chenniyappan sir and Dr. Ravi Edwin sir for your time to join us for this evening. So this is today's last session. So we'll close this session and we'll reassemble for tomorrow at 6 p.m. with the same Zoom link and same time. We'll have 4 different topics and PG program for quiz also.
Thank you, Chenniyappan sir, for your wonderful presentation. I thank all the participants who stayed till the end of the program. So please, as Dr. Subramanian told, so please join exactly at 6 o'clock, 6 p.m. tomorrow evening.
Thank you, sir. Thank you, Mohan sir. Thank you, Subramanian. Thank you very much. Good night.
Very good, sir.
Thank you, sir.
Thank you, everyone.
Thank you, Subramanian. Thank you.
Thank you, sir.